Hello and welcome to the Schomburg here in Harlem for the Digital Health Initiative 2024 Conference, Health Equity in the Digital Era. We have a few housekeeping slide, or a slide with a few housekeeping points. We can put that up really quickly. Can you guys hear me all right? Yes? All right. All right, so first and foremost, don't be that person. Please silence your phone. Nobody likes that person. Don't be that person. You can't eat in here for obvious reasons, so please keep the food outside. The restrooms are out that door to the left, right when you come in. In order to download the app for the conference, please see the email that was sent last week. Go ahead and do that now while I'm talking, I guess. If you would like CME credits, please see our website or the PDF that's within the mobile app in order to claim those. Also, like when you're here, you're going to learn things, right? So we want you to take that information, implement it in your places of work, in your personal lives to help spread the knowledge about digital tools. Take the opportunity to network. We have a very diverse group of people here. We have community-based organizations, hospital networks, obviously public health and state and government folks. So talk to each other, find ways to work with each other, and incorporate these digital tools. And this is a really cool place. You saw the video. Please check it out during the breaks. The Langston Hughes exhibit is phenomenal. He was an amazing person, so learn about him. And now it's my pleasure to bring on our fearless leader from the New York State Department of Health AIDS Institute, Joe Kerwin, our director.
Good morning, everybody. So I want my colleagues in the Digital Health Initiative to realize that some of my talking points are coming from an iPad today, and that, as opposed to paper, is a real advancement for me. So for their work and influence on me, as evidenced by my words today, I'm grateful. I'm Joe Kerwin. I'm the director of the AIDS Institute, as Mark said. And on behalf of the AIDS Institute, we are truly honored to convene all of you here today at the Schomburg Center for Research in Black Culture, a historical cultural institution devoted to the research, preservation, and exhibition of materials focused on African American, African diaspora, and African experiences. Our gathering here today reinforces our collective commitment to providing innovative and inclusive care, services, and education inclusive of digital health. I want to extend my special thanks to my colleagues in the AIDS Institute's Digital Health Initiative for organizing this inaugural event. The initiative provides leadership in the development, research, and integration of digital tools into our education efforts and our programmatic activities. Digital health is an essential strategy that has transformed access to testing, care, and treatment of HIV, hepatitis C, and sexually transmitted infections, as well as access to life-saving naloxone. The AIDS Institute has long supported digital health strategies, such as our HIV self-testing, telehealth, social media education campaigns, and the medication for substance use treatment and electronic referrals, or a program that we refer to as MATTERS. This program partners with providers across the state to rapidly link individuals with substance use disorder to treatment and resources. While digital health has facilitated access for some, we all know that a digital divide continues for certain populations. And so the theme for this inaugural event today, Health Equity in the Digital Era and its implications for diverse communities, recognizing that inequities persist for certain populations in terms of access to prevention, care and treatment of HIV, hepatitis, sexually transmitted infections, and for persons who use drugs. Throughout the conference today, it is our hope that there will be candid conversations about the challenges that persist and that prevent digital equity. Those include technological constraints, service limitations, security concerns, poor digital literacy skills, or balancing digital and in-person services. I hope these conversations today will serve as a catalyst for all of us to support the creation of new opportunities to empower underserved communities in their use of technology. As we listen to the various sessions today highlighting the latest tools, innovations, and breakthroughs, let us remember why we're here: to improve lives, to bridge gaps, and to create a healthier New York. We'll work together to narrow the digital divide by designing solutions that are accessible, inclusive, and tailored to diverse needs. And I'm looking forward today to learning with all of you. We were to be joined today for today's program by Joanne Moore, who is our Executive Deputy Secretary. We got word late last night that Joanne had an issue that she needed to deal with at home, and so she was not able to be here with us today, but she did send me her talking points and asked that I share those with all of you, so I'd ask you to bear with me for another minute. Joanne notes that equity is not equality. Eliminating disparities means addressing the social determinants of health, and we must look at the factors that influence a person's health and well-being. For example, do they live in a safe environment? Is the air they breathe full of pollutants? Do they have access to transportation, healthy foods, and green spaces? Can they access health care in a language in which they can communicate? Our conference today addresses another critical determinant of health and well-being: digital equity. What is the digital divide, and how does it continue to impact public health? Online tools in healthcare, such as patient portals, have evolved rapidly to become commonplace. Patient portals, for example, give patients online access to see their medical records, schedule appointments, request prescription refills, and communicate with their providers. Yet, the proliferation of such digital tools in patient care, as we know, does not mean that everyone is able or willing to use them. Research indicates who is less likely to use a patient portal and why. Multiple studies have shown that inequalities such as race, socioeconomic status, and other socio-demographic factors affect the use of these online tools. Artificial intelligence also may in fact be the elephant in the room. But this elephant, Joanne notes, is not going away, nor should we want it to. The use of AI is expected to be particularly helpful in primary and preventative care and spaces. It functions in diagnostic and care management and can help to prevent burnout and increase the capacity for clinicians. Digital technologies create benefits for those who use them. This can increase disparities for those who do not or who are unable to use them, especially when healthcare systems are increasingly relying on digital technologies over in-person contact. Understanding and documenting these disparities can help guide the development of resources and practices that can pave the way to more equitable access to and use of digital tools. Since 2010, when the Digital Health Initiative was established within the Department of Health SAID's Institute, this has been DHI's focus. DHI researches, develops, and implements health-related, technology-based interventions and digital tools, and continues to explore and evaluate new digital health interventions and develop digital health planning strategies. Given the wide range of barriers to digital technology that currently exist in healthcare, there is no one-size-fits-all response. But our digital health team seeks to respond to people where they are. And two prime examples of the unit's work includes their digital health trainings to enhance practices among HIV program staff in order to improve patient-provider communication and patient access to services. Why Get It, an app for HIV care? Why Get It engages, links, and retains people in care who are living with various health conditions through a mobile app and an award-winning digital comment titled Tested. This has over 17,000 followers and includes over 1 million views across several popular digital platforms. Our DHI colleagues have put together a fantastic program for us today. And as I said, I look forward to learning with all of you today. Thank you very much.
All right, thank you very much for that introduction, Joe. There should be music playing, but all right. We'd like to introduce Dr. Sophia Richardson for our first session about disparities in digital health spaces. Dr. Richardson will be speaking about foundations, ongoing work, and the path forward, and followed by Mr. Michael Short. He's a managing director of the Firefly Innovations at the CUNY School of Public Health. And Dr. Richardson is also amazing and has done lots of things. She can start coming up. She is an assistant professor and director of the Division of Digital Health Equity and Department of Health Informatics at NYU Langone. Thank you.
Perfect. Hello. Hello. Good morning, everybody. I actually grew up not too far from here. And so I'd come here quite a bit as a kid, actually, to learn about and experience Black culture. So when the organizing team actually invited me to give a talk today, really what I thought was, you had me at Schomburg. So needless to say, I'm actually really happy to be here. And today I'm going to talk briefly, but hopefully with a little bit of nuance, about digital health equity as I see it, a couple projects we're just getting started at NYU, and some principles I think that are important to sort of move us forward. So as was said, I'm Sophia Richardson. I actually have 3 jobs, somehow just one paycheck still, but 3 jobs. I'm an internal medicine physician, I'm research faculty, and then I'm director of digital health equity in the Department of Health Informatics and in the Institute for Excellence in Health Equity. And so today I'll mostly be speaking in that last role. So I just wanted to make a quick note that really that last role underlines NYU's really commitment to the cause. So this here actually is a graphic detailing the ideal digital health equity leadership at an academic medical center. That was published by AAMC and actually authored by Dr. Rodriguez, who we'll hear from later on today. And this actually represents our structure at NYU. We have lots of hands-on sponsorship from the director of the Institute of Excellence in Health Equity, our CIO, and our CMIO, and you can see the rest of our team there. All right, so let's start at the beginning. What is digital health equity? So this is how I've chosen to define it, okay? The assurance of equitable access to digital health technologies, as well as the equitable distribution of benefits and harms from these technologies. Achieving digital health equity requires us to reimagine the inherent challenges presented by the rapid digitization of healthcare as opportunities to advance health equity. So equitable access, which I'm sure we'll talk about a lot today, that's I think what first jumps in people's minds when they think about digital health equity. Also, really importantly, the equitable distributions of benefits from these technologies. So access doesn't necessarily mean that everyone's getting the same benefits from these technologies. And also harms as well, right? So that often gets forgotten about. I think we're thinking about that more and more in the context of AI. And then lastly, really reimagining the inherent challenges of tech. as an opportunity to advance health equity. So it's important here to note that digital health equity, it's about digital, of course, but it's also really about clinical health equity, right? So, for example, we want all patients to have equal access, let's say, to remote blood pressure monitoring. That's an important tool that lets patients actually monitor their blood pressure from home, send that remotely to their care team, quickly iterate, get blood pressure down as quickly as possible. So we want access, but then we also want those tools to be designed in such a way that all patients experience the benefits, let's say in the experience of using the technologies equitably, right? That there aren't any unforeseen harms, and that lastly, we're seeing real benefits in terms of patient-relevant outcomes, like in this case, stroke. And then it's important to note here that equity is also a little bit of a ceiling, right? So the best version of digital health equity actually lets us leverage these important tools to optimize the health of disparity populations, even beyond that of majority populations. So lots of elements to digital health equity. What do we mean by digital health technology? So I mean everything. I think often we think about the first four there: mobile health, wearables, remote patient monitoring, telehealth, but also the EHR, patient portals, clinical decision support, ML, AI, all of it. All right, so I'm sure we'll talk more about this. You guys are familiar with this. High-tech, the High-Tech Act of 2009 was a huge driver of tech in medicine, really pushed for the adoption of EHRs, first in hospitals, and then in outpatient care centers. You can see a huge jump from less than 10% in 2008 to really almost 100% now in hospitals and outpatient centers. The patient portal, this was in 2020. 60% of Americans were offered access to a patient portal. So big jumps. And then COVID was the next probably huge driver, right? So we saw in terms of telemedicine use. Physician use rates jumped from 15% to close to 100% now. The mobile health market in the US, $77 billion, huge. And then of course AI, which we'll talk more about later today. Broad use of medical algorithms in hospitals, insurance companies, and then ChatGPT already in use, which I'll talk a little bit more about later on. This is actually Amy Webb at South by Southwest just a couple months ago. She is actually a quantitative futurist, announcing that we're entering into a tech super cycle driven by these three technologies: AI, wearable devices, and biotechnology. And she's calling all of us Generation T, so we're living through a transformation. And you'll notice these three technologies are all really relevant to health. All interventions really are at risk of creating intervention-generated inequality, right? I think we understand that here, especially in a public health context. An intervention produces inequality if it's more accessible to, adopted more frequently by, adhered to more closely by, or more effective in socioeconomically advantaged groups. So it's very important for us to think about, because tech has a tendency really to meet all these different criteria here. And of course, the unfortunate irony is that really groups that are socioeconomically disadvantaged are where we're seeing the worst health outcomes, and so often those groups end up being left behind. And we're already seeing some evidence of this. So already there are hundreds of studies demonstrating disparities in patient portal use. In elderly people, racial minorities, persons with low SES, health literacy, disabilities. We're seeing disparities in adoption of telemedicine. We saw that a ton during COVID. Broadband access is a huge deal. 25% of households do not have access, lower rates in racial minority communities, rural communities, and then of course AI. We're seeing lots of examples now popping up of bias in these algorithms. So what do we do? So of course, in academia, we start with a framework, right? We have to have a framework. So we created this, we published this in 2022, and we really wanted to ground ourselves in the health disparities literature. So we took the leading health disparities research framework, which is everything you see outside of that blue box, and we added a layer for the digital environment. And so at the individual layer, you can see a few Barriers and facilitators you're probably familiar with. So digital literacy, access. At the interpersonal level, you can see implicit tech bias. So for example, we know that Black and Latino folks are less likely to be offered the patient portal by docs. Also interdependence. Again, these things can be barriers or facilitators. The patient-tech-clinician relationship, how that changes. At the community level, you see community infrastructure, like libraries, for example, healthcare infrastructure, tech norms in the community partners, like CBOs. And then at the societal level, tech policy, data standards, design standards, social norms and ideologies, and of course, algorithmic bias. So I wanted to share a couple of examples of projects we're just getting started at NYU. So starting with healthcare infrastructure, right? How do we make this a facilitator of digital health equity? So this is the very first draft of what will be our digital health equity dashboard. So everything at NYU is metric-based and dashboard-based. If you can't measure it, you can't change it, right? So our goal here is really to take key measures of the patient experience, so patient portal, active accounts, signups, digitally scheduled appointments, and stratify these by race, ethnicity, language, median community income, and identify disparities, target them, and close them. So, in the topic of algorithmic bias, so I do like to always include this quote, just because it's by Dr. Sophia Noble, who shares my name. She wrote Algorithms of Oppression. Policing and healthcare are fundamentally the most dangerous kind of predictive technology, that it really is a matter of life and death for people. So this is a huge issue, something we're paying a lot of attention to. Everyone knows now about ChatGPT, launched in November of 2022, quickly became the most quickly downloaded application. So Epic, one of the nation's biggest electronic health records, actually partnered with Microsoft to bring GPT-4 to electronic health records. And their first use case allowed clinicians to use GPT-4, generative AI, to create a draft response when communicating with patients. This is in messaging back and forth on my chart. This is a quick example to give you a sense if any of you haven't messaged your doctor anytime recently. This is inside the Epic user interface. You can see on the top, Sally McKee, right, saying she has a rash, what should I do? And you can see the draft generated reply saying, something simple and obvious, which is you're gonna have to come in for a visit. I can't assess you by text. But you can imagine how this makes things a little bit easier for the doc. They don't have to type this themselves. They can just send this, or they can edit the draft. It's a huge issue because physician burnout is a really big deal. So about half of doctors' workdays are actually spent doing desk work, not interacting with patients. And messages are a big part of that. So a lot of potential here. So again, grounding ourselves in the health disparities literature, our thought at NYU was, can we do an equity evaluation of this technology, right? And where should we start? So we decided to start actually with patient-physician communication quality outside of the EHR, what's already been found in that space. And it seems like pretty well established, actually, that physicians are more verbally dominant, less patient-centered, and exhibit lower levels of positive affect with African American patients in their communication, and also Hispanic patients. And that this really matters because it's associated with lower medication adherence in patients with chronic disease. So we thought, okay, is the AI potentially regenerating this in these draft responses? And this is what we found. So this was a pilot. This happened actually September, October, November, into December actually of 2023 at 3 different family and internal medicine sites at NYU, 18,000 total messages, so lots of messages, just at those 3 sites for just those few months. And we did find actually that for Black patients, a little bit less affiliation language, so less patient-centered language. actually more positive affect for Black and Asian patients. And we actually went back and looked at the patient messages and found that patients actually, the Black and Asian patients actually had more positive affect in their messages. And the AI was almost sort of responding to that. And so we thought it's an interesting start for us. I think our plan now is to look at the final physician reply, to look for differences there. And then, of course, we'll try to change the prompt, correct for any differences, and then publish our results. One of the things that we thought was really interesting about this, however, was that the AI didn't really actually have access to the patient race ethnicity, just had access to the message content, the date the message was sent, and some labs. So it was interesting that we're still finding differences even when there isn't a direct access to the patient race ethnicity. So it just underlines the importance of pilot testing all of these technologies and making sure that we're looking for harms. Okay, so a few principles I think are important as we move forward. Number one, stand on the shoulders of giants, and we're in a great place for me to include this slide here. So I think we're all familiar with the IOM report Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare in 2003. But really the field of health disparities has been going on for a very long time, with the start W.B. Du Bois in about 1897, 1906. So there are decades and decades and decades of work identifying, understanding disparities, inequities, and evaluating interventions. So we need to make sure we're grounded in the work that's already been done. Think upstream. So this is huge for us. You notice I picked two examples that were at the community and societal level. So as much as possible, we want to shift away from thinking about individual determinants and trying to shift to the community and societal levels to really make as much change as we can. And then lastly, employ an equity-centered design process. This is a project that we're working on, actually unpublished right now, grounded really in Stanford's design thinking framework. Some of you may recognize this in terms of developing health interventions. And really what we've done here, they usually start with empathize, which focuses a lot on internal reflection, shifting that to review, as in review the literature, ground yourself actually in what's already been done, and then shifting that little middle portion to a participatory design. So actually inviting folks into the define process, the ideate process, the prototype process, and also the pilot test process, and then adding a proper evaluation at the end, right? So an equity evaluation and an efficacy evaluation at the end. And then, of course, making changes and going back to prototyping and pilot testing. So I'll end here. Actually, this image that you see here is actually an AI-generated image. I asked it to show the path to digital health equity in the style of Aaron Douglas. So I thought that was pretty cool to include. Thank you.
Dr. Richardson. We'd like to invite up Michael Short to give his presentation. If you didn't see the slide for the CMEs, we will put it up after this presentation so you can take your pictures and get all your credits.
Good morning, everyone. I'm Michael Short, Managing Director of Firefly Innovations. Some context before I start my short presentation. My background is in entrepreneurship, economic development, with a specialty in scaling organizations and programs. We'll see why that's relevant as we go along. My firm assisted and advised diverse clients in securing over $320 million in various resources for projects working to solve community, environmental, and social challenges. I was recruited by this handsome gentleman, Dr. Terry Wong. Some of you might be familiar with him, founder of Firefly Innovations, distinguished professor and chair at CUNY SPH, to essentially come in and to assist with scaling his incredible organization that he and a number of grad students had put in place. Essentially, Firefly Innovations is the premier public health entrepreneurship platform at the City University of New York Graduate School of Public Health and health policy. The platform is unique among accredited public health programs, the first to launch of its kind in the country. Firefly essentially works to support the most innovative and inspiring entrepreneurs in the world that are working to solve the most pressing challenges that we face when it comes to public health, both here in the country and worldwide. Our flagship program is the CUNY Public Health Innovation Accelerator. It's an annual accelerator program supporting on average 8 ventures from various sectors each year. We're focused on solving public health challenges with diverse solutions. So whether it's masks that actually work, utilizing this cool graphene-based technology, don't ask me to explain it, but they got a lot of money from NIH, to care coordination, to mental health, cancer screening, marketplace enablement, health literacy. Really, it runs the entire spectrum in terms of all the challenges that we face. And we have some incredible entrepreneurs that are working to solve these incredible challenges. So to date, the accelerator has supported 30 ventures and 72 entrepreneurs founded in 2020. Our momentum continues to grow with surging demand and a record number of applicants in 2023. And I'm very happy to report, as I was scanning the applications this morning, we are on track to exceed our numbers from last year and have another record year this year. If there are any entrepreneurs out there, we did extend the deadline till Friday, so I'm happy to share additional details if you're interested in participating. So in just a very short few years, Terry and the team developed a network of 2,600 entrepreneurs, academics, investors, and a network of nearly 1,000 like-minded companies, organizations to share a mission of health equity. The support that we provide our entrepreneurs is tailored to the specific challenges and opportunities that they face during our 2-month accelerator in June and July, and then we provide ongoing assistance after they graduate from our program. Lots of entrepreneurs. As a lean organization, we're able to have such tremendous impact thanks to the dedication and commitment of our network of mentors. So this isn't so much a speech, it's a recruitment. For any interested parties who would like to be mentors in our program, which starts in 3 weeks, we're always looking for brilliant people to come in and advise our entrepreneurs. So please consider this to be an open invitation to join us. The entire point and purpose of our accelerator is to promote health equity by harnessing the ingenuity of the incredible ventures that we support. We provide all kinds of different services. We connect our entrepreneurs with a network, an ecosystem of different resources and what have you. But as we know, disparities in health outcomes are well documented. We all know about them, and they're part of our healthcare system. These disparities often persist in spite of new technologies that are intended to improve healthcare. However, these new technologies often exacerbate the problems. The result is what many call a digital divide, in which populations that have poor health outcomes continue to have poor health outcomes despite advances in technology and technological improvements. While we must continue to utilize new technology in healthcare to improve outcomes, we must, and this is so important, we must also ensure that those outcomes are equitable across different populations. One of the major focus areas in this digital divide, well, here's some of our mentors. Imagine your face up there, beaming, because you're so excited because Firefly is fun. Subliminal messaging. Firefly is fun. Digital divide, yes. So one of the major focus areas in addressing this digital divide is broadband access and affordability. We're talking billions of dollars pouring into this in a myriad of initiatives, both at the state level, the federal level. The FCC says that 19 million people in the United States lack access to reliable broadband service, and this is a challenge in terms of accessing a lot of these technological advancements when it comes to healthcare. Particularly, the swift adoption and uptake of telemedicine, I'm sure we've all seen commercials for it or utilized them ourselves. Telemedicine during the pandemic has thrust this concept of digital divide into the spotlight In healthcare, we have seen this discussed as technology and internet access gaps between the underserved populations and everyone else. But the purpose of this short presentation is to emphasize that broadband access is not the biggest gap, and it's not a cure-all. For example, 2018, 86% of the more than 70 million Americans on Medicaid, they owned a smartphone. They had internet access. In other words, underserved communities have and use technology. We know this. The major gap that needs to be addressed is that the digital health solutions are not tailored to the certain underserved populations, which brings us, oh, that's the next slide. Okay, so here are I was like, and the next slide. No, okay, got a little ahead of myself. But anywho, here's a great breakdown of all the different ways that they're coming at this broadband access issue. And now we come full circle to Firefly. When considering the digital divide in healthcare, instead of always looking at and focusing on what communities lack, let's focus on innovating for the skills and cultural context and technology that they do have. And what these communities do have, some of the most innovative entrepreneurs in the world. And I can attest to this personally because I talk to them, I'm interviewing them for the program, et cetera. And those entrepreneurs often have the lived experience necessary to tailor these technological innovations in healthcare to the capacities and cultural context of the populations they serve. So using telemedicine as an example, we'll look specifically at telepsychiatry. After all, we are in the midst of a mental health crisis in this country. So let's assume we do solve this broadband access and affordability situation. That doesn't change the fact that the demand for mental health treatment and mental health services currently exceeds the supply. Solving this broadband access issue will further exacerbate this problem. That's why it's not a cure-all. But that's where innovative entrepreneurs come in. That's where Firefly comes in. That's where we do our thing. One of our ventures, Sanitas Health, they just renamed Azadi Health, is developing an entirely new model for providing mental health care services to underserved patients, increasing access despite the fact that the demand is skyrocketing and we have decreasing supply. The number of psychiatrists and psychologists and therapists continues to decline year over year. But they have created this model that basically allows you to provide more services even though you have less supply of providers using this technology. It's really quite innovative. You should check it out. It was the founder's lived experience, Rodney Bell, amazing person, lived experience of the problem that led to this breakthrough in terms of service delivery. So like I said, Rodney Bell, amazing person, but he's just one example of the many entrepreneurs that need our help. And quite frankly, given the scope of what we call at Firefly the cascading crisis, it sounds, a big deal. Christ says with an E, multiple, cascading crisis of public health challenges that we face across the country, across the world. Quite frankly, we need their help too. This year we have over 100 ventures, and we're not closing our application until Friday. So far, over 100, 200 individual entrepreneurs seeking access to this innovation accelerator. These are some of the most brilliant and most promising people you'll ever meet, and they're focused on solving the many public health challenges that we face, especially when it comes to the digital divide. But given our capacity, we can only help 10 ventures. We usually help 8. I'm going to increase it to 10. Terry said to me, he's like, you're going to do that and you don't have more funding? You're going to do more even though you don't have the funding to do it? I was like, yes, Terry, we're going to increase it to 10. It's 2 more, but on our way to helping even more. But with your help, we have every intention of increasing this number in order to capitalize on the ingenuity of our entrepreneurs in solving this cascading crisis of public health challenges that we currently face. So any entrepreneurs out there, come chat with me. Any brilliant people, that would be the whole room, come chat with me. We need mentors. And we can accelerate the growth of these entrepreneurs that are fixing all of our problems. Every day we read the newspaper. I'm dating myself saying reading a newspaper. We read it on our iPad, and the world's upside down. But I got to tell you, working with these entrepreneurs, gives you hope, because there are a lot of people out there with a lot of great ideas and the ambition and the drive to make them happen. And we want you to all be part of it. So thank you very much. Firefly is fun.
Thank you, Mr. Short. We'd like to invite both of the speakers up for a quick Q&A session. Just have a seat in these lovely, very comfortable-looking chairs. Have a little water. We will welcome the audience to walk up to one of the mics at the top of the, whatever you call these steps, and ask your questions. That's right, don't be shy, you can get up.
There's got to
Sit
be
for a little while.
questions.
I'll start off with one while you're walking up. So just a quick question. So we've talked about all these disparities. I'd love to hear a little more about what each of you is doing to implement strategies to address the specific disparities with the aging population. When it comes to technologies, a lot of folks of a certain seasoned age do struggle with adopting some of these new technologies, and I'm just curious as to your thoughts on how to do that effectively.
I don't think, does my mic work? Okay, perfect. Yeah, so I think actually that last slide that I put up, detailing that equity-centered design approach to designing digital health technologies really applies here. So we talk a lot, a lot of my presentation was actually about maybe race, ethnicity, language, but age is huge. So starting with the design thinking framework, like I mentioned, that the D School put together, and then making modifications to that, really is just about doing proper equity-centered inclusive design to make tools that are as easy as possible for all kinds of people to use. And so I think we're thinking a lot about that at NYU. We try as much as possible to push everyone through a single app, which is actually the MyChart app. But there's lots of add-ons to that we call Care Companion. And thinking as much as possible, how do we design those to be as easy to use as possible, as usable as possible, test them with folks, like you mentioned, that are a little bit older. Yeah, so I would say.
Absolutely. So that's the beauty of entrepreneurship, is the fact that you, as the entrepreneur, need to go through this discovery process in terms of your clients and your customers, finding out their needs and their challenges. And when it comes to elderly population, one company that just pops into my head is Oatmeal Health. They do AI cancer screening. So in the news, if you go and you look, CNN and talking about how we're on the verge of what they're calling a cancer time bomb. Kind of hyperbolic, but if you look at the data, it's kind of scary. You have millions and millions of people that didn't get their cancer screenings during COVID for understandable reasons. They're rescheduled or canceled their appointments or this or that. Millions and millions of people. Oatmeal Health is working, especially with the elderly population, to make it so that they can access those resources. And doing their customer discovery, determined that the technology wasn't the issue. The elderly population would use the technology to figure out that they could schedule appointments, et cetera. Their challenge was the transportation to get the screening. And so through that discovery process, looking at every little step, they're able to adjust their entire approach. And now essentially they pay for the transportation for the elderly individual to get transported, to get their screening, and then there's some sort of stipend involved as well. So, beauty of entrepreneurship. Find the pain points, figure out a solution, and better serve your clients. And sometimes it'll be things you didn't even think of, right? So we're talking about, digital disparities, but really it's grandma needs a ride to the hospital. Okay, so if that's the challenge, let's figure it out and let's solve it. And that's just one example.
Uber, yeah. Good point, very good point. We have a question from the audience member.
Hi, good morning. This question is for Dr. Richardson. So I provide more so direct services to patients, so patient experience is very important to me. When looking at the Epic AI generated like my chart messages, considering that medical services are usually in person, what can we do about any kind of discrepancy between maybe the positive affect in written messages versus maybe a not so positive affect from the same provider in person? And then also, do you maybe think that having that AI generated written communication will help reinforce that positive experience in person from either client to doctor, doctor to client?
Yeah, it's a great question. Yeah, that's tough, right? It's tough to sort of move the needle on that. I guess as somebody who's really oriented around tech, and particularly the electronic health record and clinical decision support, you know, I think beyond quite obviously like training, right? I think as much as possible actually improving the clinician experience, so taking some of the workload off of docs lets them be at least the best version of themselves. So I'm sure, you know, you all will sort of get this when you're in a rush and you're overwhelmed and you're completely burnt out, and you're being, you know, asked to see way too many patients per day. You're not really going to be the best version of yourself. You're more likely to slip into more negative affect, probably particularly with certain patients, right? So I think I mentioned, you know, a lot of the patient experience stuff here, but I'm also really interested in improving the clinician experience, particularly at our federally qualified health centers. So at least docs can, you know, be the best that they can be.
Other questions? Oh, all right.
Morning, everyone. My name is Tina Burke. I work at a federally funded medical health center, and my question is, how do we, as a federally funded medical center, bridge or address this gap between digital literacy and just literacy on a whole? We saw during COVID where a lot of patients, we had to help them download like WhatsApp just for communication. And as we're transitioning to a more digital platform, and it was said earlier, they don't even want to use that check-in portal. So how do we bridge those gaps? Because we do have a high quality of literacy, and now with this new brand of digital literacy, how do we finesse between both? Thanks.
How do we finesse between both? Very carefully. That's a challenge. In terms of the entrepreneurial approach, you take it step by step, and you do a customer discovery and chat with the clients and the customers that you're serving, and identify those pain points and work to accommodate and serve them. For example, we found that when it comes to health literacy data, well, this would be less data-oriented, but when it comes to youth, the youth population, a big challenge. A lot of misinformation, but just not a lot of quality information. So one of our entrepreneurs that we support, Sonny Williams, amazing person. You're going to hear about him. I guarantee it at some point. He's working with Sesame Street, and it's called Tiny Docs. And they incorporate the digital literacy and the health literacy, primarily focused on the youth. And there aren't a lot of services that do that. So I can answer for the youth side. And the youth side answer is Sonny Williams. Tiny Docs, look them up.
Yeah, so I think what that question made me think about, which, you know, I think is more important for our group, is making sure that we support non-tech solutions when that makes sense. So if you have a patient population that it sounds like what was said, doesn't want to check in, doesn't even want to check into the really inclusively designed WhatsApp version of the check-in, is the best thing for them to just provide personnel, to provide a human-to-human contact. And so I think we often forget that a lot of times digital health equity is actually just providing human beings to help people get the things that they need.
Thank you. Looks like we have some more folks back there.
Great. Good morning, everyone. Thank you so much both for your presentation. My name is Shanaz Cherry with the Greater New York Hospital Association. I just was curious on your thoughts about the end of the Affordable Connectivity Program, which is the federally funded program that provided discounts on internet services for many families across the United States. We've been advocating for Congress to continue the funding for the program because it's primarily for telehealth access and some other programs that you've mentioned. So just curious, any thoughts around maybe the impact of the end of the program or just other outcomes or positive impacts that the program had in the previous years?
For questions like this, I'm very pleased to say the truth. And the truth is that I am a taxpayer-funded position and therefore cannot take a political position on that issue. However, what I can tell you is that any initiative that's working to broaden access to these types of services, we support. That's what we can say. But I can't take a position because we're publicly funded.
Yeah, I think it's a loss, obviously, right? I mean, it's my understanding that some of the groups that work at NYU that were focused on that, they had trouble sort of operationalizing it. So hopefully in the future we'll get more support. And then I think it's also really the role, hopefully, of big healthcare systems to step in and provide those kind of resources.
Good morning. I'm Jennifer Wilson from Candlewood Community Health Center. I was wondering, with the MyChart AI pilot, if you ran into any resistance or hesitation from other providers, building new habits, breaking out into new technology. We've encountered a wider range of buy-in from the provider standpoint, so I'm wondering how you address that.
Yeah, definitely. So I didn't mention that, but yeah, there's a whole other stream of work going on. Funny enough, actually, we didn't get really a huge adoption actually of that technology because docs are just so routinized in terms of exactly how they type their responses, the tone they're used to presenting. I didn't show this also in the presentation, but there is some inkling that AI might actually provide more sort of empathetic responses to patients. And so a lot of the feedback we got from docs actually was that almost the message was too empathetic. It didn't seem like it was coming from them. It was too long, it was too friendly, it was too fuzzy. And their patients would sort of be confused as to where this was coming from. So we've made quite a few iterations, actually, and eventually, hopefully, it'll be personalized, right? Hopefully the AI will actually read all their messages and send something that's sort of in their style, maybe a little bit warmer. So yeah, it's just a work in progress.
Hi, good morning. My name is Michael Cruz, he, him pronouns from Mount Sinai. I have 3 questions. I'll start with the simplest one. This is for Dr. Richardson. Can you define verbally dominant? You wrote that there, but I wasn't really clear what that meant with regards to physician communication.
Yeah, good question. Yeah, so I would say telling someone what to do, kind of the worst version of what you think of with a doctor, short, curt, cutting the patient off, as opposed to really, patient-centered is more of a we, figuring out what their values are, coming together as a team to plan their care plan.
All right, great, thank you. My other question is, does generative messaging speak other languages?
No, not yet.
Okay.
But yeah, obviously, always a great question.
And then my last question is, how do we ensure that AI isn't perpetuating health disparities? Because we've heard that AI can be racist in its responses to people. So I'm just kind of making sure that when you're incorporating that into the medical record, it's not perpetuating those stereotypes or that kind of language. Even though it doesn't know race, it seemed to still know something.
Yeah, I mean, so what I think as a researcher is that we have to test everything, right? So I think just like we would test Lipitor before we let people use it, right? It has to go through clinical testing to make sure it actually works, where we look for harms. And I think sometimes in the tech space, something just seems kind of shiny and cool and a great idea, and we go for it. And so I'm glad actually that in NYU we started with a pilot test, just 3 sites, and we need to be looking back, like I said, into the literature to see inklings point us in the right direction of where harms might be, and then looking for those harms and making sure we're really getting benefits before we expose all of our patients to these technologies.
Hi, good morning. My name is Melanie Dolfo. I'm from Aperture Community Health Center, and I use she, her pronouns. I think something that I'm thinking about is that while AI is sort of a hot topic in digital health, something that I find challenging is that recently the Office of Civil Rights had this guidance that was released to prevent health centers and health systems and health organizations from being able to do any tracking of maybe users that we encounter in the digital world. And I think I recently went to a health marketing conference where this was also a discussion on how do you then measure your, like how effective you are as an organization. And so I think there is this like real tension between being able to protect privacy, but at the same time also almost like not being able to do our work because we're not able to personalize like content and be able to follow up on people that maybe are visiting our websites and our socials. And I was wondering what are some of your thoughts around how this, I think, impacts like our conversation around digital health and equity, particularly because like healthcare industry is such a big target for, oh my God, I'm losing my words, but people who are doing ransomware attacks and hacking into systems. I think just, thinking about like how hostile sort of the environment is for health organizations that are just trying to help people, and then you've got big tech and also hackers on like, side by side, like in the landscape.
Yeah, I don't know if I have a solution there. I think those are all really great points. Yeah, healthcare is always so tough with all the regulation, like you mentioned. Privacy is huge, and definitely a target. So we're always trying to balance all of that and really just do the best that we can, I think.
Our third session will be dealing with safety issues, so we look forward to answering that question a little more thoroughly for you.
Hi. Good morning. My name is Norma Ford. I come from a child welfare world, and we're partnering with the folks on Why Get It, right? And so my question is related to a part of our agency focusing on Office of Refugee Resettlement. So we are looking at folks in the community who are newly arrival folks, who are in many levels of challenges. And our Article 31 clinic started working with folks in the community. My question is primarily, how does this level of research is looking at this new coming folks into our present space?
Yeah, so I think I mentioned this towards the end of my definition there of digital health equity, but really, I'm in this field because I believe in the potential of technology. So, the best version of these technologies really help lower resource healthcare settings, leverage the resources that they do have, and hopefully get folks to optimize their health as much as possible. I think you're mentioning a particular community, right, that really probably needs that support.
Thank you.
Okay, I think that's it for the questions. Can we give our speakers a round of applause, please? As promised, we'll put the slide about how to receive your CME credits and the information you need to do that up now. There we go. If you need it, take a picture, please. We'll leave it up for a little bit. We're a little ahead of schedule, so we'll be taking a 5-minute break. Feel free to stand up, stretch your legs, go get some more water or whatever's out there to eat, and come on back in 5 minutes. Thank you, guys. Great. I really appreciate it. We'll ask everybody to take their seats again, please. All right, I hope everybody got a chance to sort of recharge very quickly. We're going to go ahead and start our second session here. This session is called How Artificial Intelligence Has Impacted the Public Health World. And you know, that's AI. We were AI before this was AI, and it's in the AIDS Institute. So just a quick reminder, if you ever get confused, we're the original AI. We're going to be having presentations from Mark Freeman, who is the Chief Data Scientist and Public Health Marketing Specialist from IBM Consulting, as well as Beth Snyder. She's a lead analyst for Government Health and Human Services with IBM Consulting, and they will be discussing trustworthy AI for advancing health equity. All right, Beth's first. Let's go, Beth.
Thank you so much. Hi, everyone, and good morning. I'm Beth Schneider. As indicated, I've been focused more than 30 years now in providing analytics and decision support to government health and human service agencies, so it's a real honor to be here today and talking about my passion, which is advanced analytics and AI in healthcare. As Satya Nadella has said, the CEO of Microsoft, AI is perhaps the most transformational technology of our time, and healthcare is perhaps its most pressing application. I'll be starting the session by reviewing promising use cases in AI, as well as discussing the risks of biased AI. I know we had some questions on that earlier. These risks heighten the importance of really keeping AI human-centered, or as IBM's former CEO, Ginny Rometty, said, using AI as a means to augment human intelligence. In the second half of our session, Mark will be speaking on the trustworthy AI framework to design applications that are fair and transparent. What we hope you'll take away is three things. First, a greater understanding of the many promising use cases for AI in healthcare to both improve outcomes and advance health equity. Second, greater awareness of how AI algorithms have in the past perpetuated and or even amplified existing biases and discrimination. And then third, understanding of the concrete steps we all can take to mitigate those risks by applying trustworthy AI principles and methods at each step of the development and deployment cycle. But first, let's start by level setting a bit on what is AI and how is it evolving for those who may not be working with analytics day to day. Artificial intelligence, briefly stated, is technology that enables machines and computers to simulate human intelligence, to reason, to learn, to understand, and now with generative AI to interact. AI was first developed in the 1950s. But we're going through a rapid acceleration due to advances in deep learning and in the emergence of large language models, due to increased access to ever larger and more diverse data sets, and to the availability of faster, cheaper, more powerful computing. So all of those things are coming together to spur some great advances. Traditional AI, just again to provide some context, involves algorithms, and we'll hear about some of those today, designed to use available data to make classifications and predictions or to prescribe the next best possible action based on those models. Generative AI, which, as Dr. Richardson's shown, has really exploded on the scene, is able to understand existing content, but more importantly, to generate new content, whether that be text, visual images, audio, not only enhancing traditional AI use cases, but really creating new cases that we couldn't even have anticipated before, and we've already seen some of those this morning. Summarizing notes from a patient conversation, generating emails, as we saw in the MyChart portal, or even developing brand new computer code. So all of this is rapidly accelerating uses in healthcare. I've tried to summarize on one page the full spectrum of use cases across a variety of improvement areas. It's important to note that these vary in how far along they are in the development and validation life cycle. Some are relatively mature and have already gone through real-world testing. They're in clinical practice. Others are still very much in the early stages. So I thought we could quickly just go around the horn here and touch on each of these areas with one example of each. Starting with uses to inform patient care. These are among the most mature, particularly AI-assisted medical imaging. I think it's increasingly common. Some of you may already experienced AI-assisted radiation, right, to help detect malignant lesions that a radiologist might otherwise miss, or to detect, for example, cardiovascular events. Also very prominent is AI to reduce the costs of care. And a big focus here for IBM recently has been working with our clients to help them improve the efficiency of both their clinical and their administrative workflows. And I'll share some examples on that shortly. Now we will hear throughout the day, we will hear throughout the day about AI and to increase patient and provider engagement. And as Director Kerwin said, digital health is an essential strategy in this area. And we know that all of you are today grappling with the challenges of overcoming the digital divide to really bring these technologies to the benefit of all. Moving on to patient safety, there's huge excitement about the potential for AI in patient safety, because it's been estimated that some of the traditional manual methods of patient safety reporting detect a relatively small percentage of errors and don't do as much as we'd hope to prevent errors. That said, there was a good cautionary note from Clausen et al., researchers that you'll see cited at the end of our presentation, who a couple years ago noted that even though there's been widespread adoption of predictive models by large hospitals to try to identify patients in advance who are prone or likely to experience complications or other adverse events. A few of those at the time had been subject to rigorous outcomes assessment in the clinical setting, and this has really led to a huge focus on a national research agenda on AI and patient safety. And I know we'll be hearing from Dr. Bajaj, I believe, about patient safety this afternoon, so I'll let the expert speak on that. Related, though, I think to the conference theme, AI has great potential, if used appropriately, to help us reduce disparities. That's because AI excels at pattern recognition. So we can, let AI loose to look at the data and help us see both in broader healthcare delivery as a whole, or in our own clinical practice, help us detect biases that we might not otherwise have been sensitive to be able to make the appropriate remedies and improvements. And then last and really longest term are the opportunities to advance new treatment options, particularly in prescription drugs. We all know the lengthy cycle to develop new pharmaceuticals, and AI is promising to really shortcut that and reduce the cost by facilitating new drug designs and helping find new combinations of existing pharmaceuticals. So that's a broad overview. I'd like to turn now to just a detailed walkthrough of some use cases from IBM's work with our clients in healthcare. Starting first with analytics that we provided to the Rhode Island Department of Health at the height of the COVID-19 pandemic. Like other states, Rhode Island was hard hit and very challenged to provide timely, accurate information to the whole array of stakeholders to guide decision making. And the Department of Health, their data team was working very diligently, but this pandemic hit so abruptly, right, that there wasn't time to get in place the system enhancements or the additional staff needed to keep up with the huge volume of data that was being submitted from hospitals and laboratories and other facilities. RIDO partnered with IBM Consulting, our data engineers and data scientists, led by Mark, whom you'll hear from shortly, built a data lake, automated the data processes, accelerated reporting, and conducted AI and other advanced analytics with the end result that the state was able to see a 30% improvement in the accuracy with which they could forecast new outbreaks. And they were also able to achieve an 80% rate of accuracy in determining the cause of hospitalization for individuals who tested positive in the hospital. Were they really suffering first and foremost from COVID, or was that incidental to some other underlying disease? And that distinction was very important to the state to help them measure the spread of the pandemic and assess the effectiveness of their vaccine efforts. Turning now to our next example, we'll get down now to the individual treatment level and focus on a case of predicting the onset of Alzheimer's disease. The earlier the disease can be diagnosed, the better the chances of delaying its progression. IBM Research and Pfizer partnered in a study that was one of the first of its kind to use individual speech patterns to predict within the general population who was likely to go on and eventually discover Alzheimer's disease. The researchers used data on healthy individuals with no known clinical risk factors from the Framingham Heart Study. So, as you know, there was extensive follow-up on those individuals such that they could determine who eventually did go on to develop Alzheimer's. The research team built an AI model that used 1 to 2 minute samples of speech from a standard cognitive test administered during physician office visits. And the model was built to account for multiple confounding factors. The results, which were published back in 2020, found a significant increase in the accuracy. It was a 71% accuracy relative to a baseline of 59% that could be achieved with existing clinical scales at the time that were based on other biomedical data. So, significant advance, and that team has since gone on to try to use speech patterns to detect early on psychoses or schizophrenia, other conditions. Now let's turn to 2 examples in using AI to improve workflows. The first is from work we've done with a large healthcare payer to improve the experience in their provider call centers. This example focuses on chatbots. We're all familiar with them. We're all frustrated with them. But I think the example highlights how generative AI can really improve the experience with that virtual assistance. Call center agents rely on a knowledge base to answer questions, based on all the relevant policies, and manual search can take a lot of time, and that frustrates the provider office staff who are calling in, and takes a lot of their time. So IBM worked with this client to address this challenge by providing our Watson Assistant chatbot enhanced with generative AI, this is the next generation, to enable quick and accurate retrieval of the answers that were needed. And the results, I think, just illustrate again what generative AI is facilitating. There was a 90% reduction in the effort involved versus prior manual search, 10 seconds was how long it now took to get an answer, whereas before it took 3 minutes. So that productivity, along with the satisfaction of the call center agents and no doubt the provider staff, that they were getting accurate answers that much more quickly. And then one last use case, again, another manually intensive health plan process that impacts providers and members, and that's prior authorization. Prior authorization is a tough process because it's based on forms and documents, and you need to extract information from those to, make the correct answer. It's error prone because of the heavy text involvement, and this makes it a perfect application for AI. So IBM worked with this customer to put in place an end-to-end application that both ingested and digitized the information from all those documents, pulled out the relevant clinical information, and then compared that to the clinical policies that it pulled, from the health plan information, and summarized that as a job aid to the medical reviewer. And again, the results were quite striking. In an initial pilot that just looked at the 5 procedures that accounted for the bulk of PA reviews, the health plan was able to achieve a 50% increase in the speed of medical necessity reviews, and it took less than 2 minutes for the medical reviewers to get that information presented to them. So productivity gains, cost savings, and a better experience all around. So very impressive results. So we've seen that AI is already producing some very impressive results and offering even greater advances, but we all need to do our due diligence to assure that we are avoiding bias. And by now, there have been many well-publicized examples of how AI, both traditional and generative AI, can bake in existing disparities or even amplify them. One of the earliest studies in this area, and I'll show you some of these, was by Obermeyer back in 2019, and they found that an algorithm that was widely used to help identify individuals who would most benefit from care management services really discriminated against Black and other disadvantaged populations because it defined medical need or medical risk based on prior health care costs. As a result, people without access to or the ability to effectively use those costly services were defined as lower need and didn't qualify for the program. And when these authors made a correction, they instead based medical need on the number of underlying comorbid conditions a patient had. They found that the percentage of Black patients who now were deemed eligible for the program increased from 18% to 46%. So a very dramatic difference. There have been health equity issues identified as well, with a broad range of predictive algorithms including those shown here, to used for such purposes as measuring kidney function, predicting survival rates from colorectal cancer, or even, and this is dear to my heart, assessing the likely success of a woman to have a successful trial of vaginal birth after cesarean section. And a 2020 publication by Vyas et al. Really summarized how many of these algorithms have included adjustments for race and hit on what the implications of that may be. If blacks or other disadvantaged populations, and in this case, race is really the issue, if black patients are systematically and inaccurately identified as not meeting an algorithm's given threshold, then they will not be referred for services from which they could benefit. And these algorithms were developed, looking at the data. There was an association between race and outcomes, but too often there wasn't attention to, well, what's causing that association? How and why is that being manifest? And the assumption was that it may be, it must be biological, when in fact we know that very little of the variation we see in differences in racial differences in outcomes can be attributed to that. It's really more an issue of structural racism and the issues with social determinants that presents. So without explicit attention to the fairness of the algorithms that we construct and deploy, there can be serious unintended consequences, life and death consequences, as we heard mentioned earlier this morning. So I'd like now to invite Mark to join us and present on the Trustworthy AI Framework.
Thanks for having us here to talk with you about the promise and the risks of AI, and Beth did a great job kind of laying out some of the mistakes that have been made to date in prematurely pushing AI and machine learning solutions into clinical care settings where we hadn't done due diligence. And so I want to talk to you about I guess for lack of a better term, a protocol for mitigating bias in these sorts of AI and machine learning solutions. Let's see. There we go. So Trustworthy AI is a framework that has developed over the last decade, and it's really a collaboration of machine learning engineers, data scientists, stakeholders really across all applications of machine learning and AI, not just in healthcare, but IBM is a big contributor to this open source collaboration that's come to be labeled as Trustworthy AI, and it provides a way for us to develop AI and machine learning solutions that are fair. And so I want to talk just real quickly about 4 components of what constitutes the Trustworthy AI framework. One is when we're designing a solution, and we want to design it by design with fairness. And a good first step toward doing that is co-design, as was talked about earlier, and making sure that our design teams are representative of the users and the beneficiaries, the intended beneficiaries of those solutions. But beyond just having inclusive design teams, we also need to bake in processes to detect bias where it's occurring. And so there are a set of well-established bias detection metrics that are now being used in the development of AI and machine learning solutions that enable us to evaluate not only our data, but also our algorithms, the mathematics behind how we're using the data to generate predictions or recommend courses of action. And I'll talk about some of these shortly. So At the heart of all AI and machine learning solutions are really two components, right? We have data, and very often that data is administrative data. We're building data, so Beth talked about this prior authorization solution, and that solution was built on data not generated necessarily from an experiment, but generated from the course of care. And that course of care exists within a healthcare system that we know inherits a lot of historical biases. And so the data is likely to maybe have biases in it as well. And so we need to assess our data to see if it's biased. So for example, are we adequately representing historically underserved groups? One thing we can do is make sure that the kinds of data elements, the features that we're using to develop our solutions are not bias-laden features themselves. So are we using, for example, race or gender that actually proxies for something else? So the race-based adjustments that Beth was talking about, are we including those features in a mistaken way in our solution? We can also, where our data it doesn't adequately represent the groups of users and beneficiaries we're trying to reach, we can reweight the data so that it more fairly represents the groups that we're working with. Now, we can also talk about mitigating bias in the algorithms we use. And so there are ways now, the Trustworthy AI framework has actually developed ways to train algorithms so that they adjust for bias and make sure that the outputs that come out of an AI or machine learning solution aren't perpetuating the biases that have existed in our healthcare systems and society at large. Finally, if we get this far and we say, hey, we've got a potentially valuable solution here, let's put it in the hands of users. Let's start using it. We need to have processes in place to continue to monitor that solution. Now, we've all known as machine learning engineers and other technologists, we've known that we need to monitor these types of models to make sure that their accuracy is maintained. But the emerging practice now is not just to monitor drift and accuracy, but to make sure that bias doesn't emerge in the solution. And we should have policies in place to make sure that if we detect bias in a solution that's being used, that we have clear rules to retrain that solution or take it offline until we've been able to mitigate the bias. So let me talk to you real quick about some of the methods, and I'm not going to go into detail here. I know that some of you are technologists and others of you are program managers, but you may be working as part of teams to develop custom AI solutions in your own organizations. You may be working with vendors who are doing that work with you, doing that work for you on your behalf, and you should be asking them what their approach is to mitigating bias in the algorithms that they're baking into your solution. And so, what are they doing to assess the data? And generally, we talk about these innovations as pre-processing innovations. Have we analyzed the data to see if it is reflecting bias? What are we doing to correct that? Are we reweighting the data? Are we employing some of these other innovations? There's also, of course, algorithmic in-processing methods that we can use, and some of these I've listed here, and when you get the slides, if you're interested and curious, you can access the research to this. And then finally, in post-processing, when we go to deploy a solution, what methods are we using to make sure that the output, so for example, am I predicting this is a prior authorization that we should approve? What are we doing post-processing to make sure that privileged groups aren't benefiting more from accelerated prior authorization than unprivileged groups? And then real quickly, some of the bias detection metrics that are very common. And again, I don't want to bore you with the technical details here, but if you're working on teams that are about developing AI solutions, or you're working with vendors who are bringing you AI solutions to benefit from in your organization, you should be asking them, what kind of bias detection metrics are you using in your development process to make sure that we're not pushing a solution into users' hands that are going to perpetuate bias? And so some of the more commonly used metrics are about statistical parity, disparate impact. All of these measures share some common characteristics. They each have an ideal value. So for example, statistical parity, the ideal value is 0. And what that means is that there is no difference between the favorable outcomes for an unprivileged group versus a privileged group when we compare the output of an algorithm. Very rarely do we achieve that ideal value in practice, but based on research for each one of these metrics, we've established a range of what's considered fair. So for example, when we talk about statistical parity, and if we calculate that metric on some AI solution or machine learning output that we're looking at, we want that value to be between -0.1 and 0.1, which typically indicates there's not a substantial difference between the benefits going to a privileged group versus an unprivileged group. So, I've talked so far a lot of concepts, right? I hope I haven't bored you too much. But what I want to now talk to you is, what does this actually look like in practice? And so one kind of neat thing about this open source collaboration framework around trustworthy AI is a lot of tools that are freely available and can be used by anyone who's developing an AI or a machine learning solution, so that, for example, they can make sure that the solution's fair. And so one of these toolkits as part of the Trustworthy AI framework is called AI Fairness 360. And what I'm showing you here is an example analysis. So if we think about that prior authorization solution, and we may have had an original iteration of that solution, and what we're trying to do is see if we can expedite prior authorization for bariatric surgery. And what we've done is say, are we getting equal benefit in the deployment of that solution for a privileged group, in this case based on race, white, versus an unprivileged group, non-white? And I'm simplifying the groups here for presentation purposes, but they could be extended to look at multiple different groups. And so maybe that original solution that we test, we want to make sure we're testing it for fairness, testing it for bias. It's showing problems in statistical parity and disparate impact. And so that original solution it looks like something, we don't want to deploy that, because what it's going to do is perpetuate the biases that in this case happen to be in the data. And so after we apply reweighting, which is one of the methods I just talked to you, so we get a more balanced view of the data so that unprivileged groups have equal representation with privileged groups, we're able to correct the kinds of problems that we see. And so this is all about baking fairness in to the development and the design of AI solutions. So as Beth said, there's a lot of promise there, but we need to do our due diligence and make sure that what we're putting in users' hands, what we're putting in clinical settings, correct for these types of problems that we know can occur, and there's a way to do it. But again, so we got to a solution and we pushed it into production. It's in a clinical setting. Our nurse practitioners are using this prior authorization solution every day. We need to continue to monitor that. And so another tool set that's part of the Trustworthy AI framework is called AI Fact Sheets 360. They all seem to end in 360. But what this does is the conventional metrics around accuracy and those sorts of metrics that machine learning engineers are familiar with are supplemented with these fairness metrics. So in the same way that we've always analyzed predictive models and machine learning solutions in production, we're not just looking at predictive accuracy alone anymore. We're looking at things like disparate impact. We're looking at things like statistical parity difference, which are kind of these technical terms that allow us to monitor that this solution continues to be fair. And you should ask your vendors, if you're part of a team, what is our plan to monitor fairness for our solutions that get pushed to production, right? And if there's not an answer, a good answer to the question, then one solution to it is, I want you guys to use the trustworthy AI framework. I want to see fact sheets, and I want to have continuous monitoring of our solution. And if we start detecting problems, we need to have policies as an organization to take them offline, right? All right. Key action items, which are, I think, similar to key takeaways, but when you go back to your organizations, and I think in the coming years, you're going to find yourself involved either directly or indirectly in the development or deployment of some kind of AI technology, be advocates for fairness by design. Make sure that as that is getting customized or configured for your organization, that fairness has been baked in to the solution. What ways are we using to detect bias in these solutions? And so some of these metrics and methods that I've talked to you about being able to detect and mitigate bias, make sure that that's part of the development and the solution monitoring. And so that's the last key action item, is if you are in an organization that's already using an AI solution, go back and ask the question, how are we monitoring this for bias? Do we have policies in place that make sure that if we detect bias, we correct it or quit using that solution? Thank you so much for your attention. And Beth and I will sit down in the comfortable chairs here, and delighted to take your questions.
All right, we're going to open it up for questions. Again, AI is very scary. There's a lot of dystopian Terminator comments and jokes to be made, I'm sure. But it is nice to know, according to these nice folks, that the machines aren't taking over yet. So please go ahead and walk up to the mic and ask your questions. You got to have some. Everybody's terrified and interested in this since it's all over the world. I'll start off with a question to get you guys warmed up, though. So my question is about youth. One of our priorities at the New York State Department of Health AIDS Institute is prevention, and a lot of that comes from younger folks before they get into situations that are going to expose them to some of the issues that we deal with here at the AIDS Institute. So with youth, they're absolutely not a monolithic group at all. Their language changes constantly, their interests change constantly, and it's always a moving target. And so my question is, how do you keep up with targeted messaging driven by AI for these groups?
You bring up a really great question. And right now, we're in the middle of these generative AI technologies. And one thing that we know about them right now is that they're super expensive to retrain. And so a lot of like ChatGPT 4.5, I think, was trained on the internet through the year 2022. So all the urban, the dialect that's come up and the new slang terms that have come up in the last couple years are not part of that data. And so we've got to keep that in mind. So that's maybe the bad news. The good news is that every day we're figuring out ways to update these large language models more efficiently and more quickly. And I'll make a prediction. I think in the next 3 to 5 years, you'll start seeing generally available large language models, foundation models that have been updated as of last month. And so partly we're in a period where the technology, we're it's new. And so some of these problems, I think, are going to get taken care of as time goes on.
I guess my follow-up would be, how do you bake health equity into that? Because often in this sector, in the tech sector, there are big groups of folks who are left out just because the resources aren't available or the opportunities aren't accessible for a number of reasons. How do you incorporate that?
I think it's super important. And so in the same way that we talked about reweighting data, certainly these large language models have been trained on the internet, right? Everything generally available. And I think it's fair to say that probably that corpus of data has a decidedly white flavor to it. And so we need to make sure that it gets balanced in some way so that the large language models and foundation models are representative of the different ways in which English and many other languages throughout the world are spoken.
Thank you. We have someone at the mic up there.
Hello, my name is Jackie Seitz from Legal Action Center. I'm a civil rights attorney, and I work on privacy and anti-discrimination protections. I was curious about the emphasis on fairness and avoiding bias in your presentation, which is slightly different from the concepts of health equity that were discussed previously, particularly Dr. Richardson's focus on making sure the harms and benefits are equitably distributed. So I was curious to hear how you see the role of health equity fitting in.
Yeah, and forgive me, I probably didn't do a good job of communicating that, but a lot of like the fairness-based bias detection metrics and the ways in which the technological ways, the data science ways in which we train solutions to mitigate bias, to try to achieve fairness, is exactly that. It's about achieving equal benefit. And so if you think about that prior authorization solution I was trying to use as an example, you can think about the benefit of a solution like that as expedited access to care. And one of the biases we could detect in a solution like that is that unprivileged groups are having to still wait longer than privileged groups. And so some of the innovations and the corrections I spoke about were about trying to make access to expedited prior authorization for something like bariatric surgery equal across privileged and unprivileged groups.
Hi, David Rosenthal, he, him pronouns from Northwell Health. The one thing that I think is really important is that as we build out additional technologies, I love the ability to be able to have the interactability with those technologies. And so the open sourceness of some of the concepts you're bringing about are extremely useful for those of us that do not have the computing power or the ability to build a training data set like IBM does. And to be able to leverage that, I think, gives us all the ability to make some significant benefits from the work that's coming out. One of the challenges is obviously interoperability, different APIs that are available, and the ability to have that. And so I know the example you showed has a really nice R interface, has a nice API that's built for Python, and has another Python code that you can log into. But if you're using SAS, or you're using SQL, or you're using a different data set, or you're pulling into a different data metrics or whatever, we're kind of then stuck about how do we get the data from where we have it into something that we can use the API or the tags that are there. Is there any more work or thought about ways that we can expand the ability of these APIs to be able to access the learning sets in a way that the API is sort of a middleware that doesn't necessarily have to change the middleware interface, even though the back-end training data sets and the studies that are being done on the back end to establish fairness and to establish new learning can occur?
I think it's a great point. And so the beauty of open source is that it's widely available and generally reasonably well documented. The downside of open source is it is going to be tilted toward the dominant open source languages like Python. And Python itself is an open source machine learning library, among many other things. And so I think there are plans. I'll tell you, we do work with SAS, and they are increasingly trying to make SAS is another proprietary machine learning platform I think many of you are already familiar with. But they're increasingly trying to make their technology more interoperable with open source. So I think it's another one of those things where the technology we have today doesn't enable us to do everything, but I think the good news is as it progresses, we're going to see a lot more talking back and forth between proprietary platforms like SAS and open source tools like Python.
That's great. Thank you so much.
So quick follow-up before the next question. In speaking to the open sourceness of the data that we're getting, there are people who are never going to walk through that open door in certain communities. So when we were putting this conference together, one of the contributors did a very nice example that I'll kind of ask to the audience. I'm going to tweak it a little bit. So how many of you have heard of the word or the term the itis? Raise your hand if you heard the term the itis. Okay. So there are a lot of folks here who didn't raise their hands, and it's very colloquial, it's very community specific, and it's probably not going to show up in data on SAS, right? For those of you that do know what it means.
I'm dying of curiosity here.
There's some racial things I'm not going to get into too much detail to it, but the point is, for those of you that don't understand the meaning, think about how you would relate that to something like diabetes or being active after you eat or something along those lines, and how that won't make it into the machine learning. And so, again, how would you address that? And then, sorry, next speaker.
I think your original question, if I'm interpreting it right, is we have to make sure that the data that we're using is representative of terms like you're talking about. And I'm going to approach one of the people that raised their hand at the break to find out what it means. So I'm educated, but yes, and so I think it's important for us all to admit that right now the solutions available to us don't reflect what's happening in certain communities. And certainly when we talk about large language models and generative AI and enabling computers, machines to mimic the language and the conversational interaction that we would have with a human being, that there are many communities, unprivileged communities, that aren't yet able to benefit.
Thank you. Next question.
Hi there, my name is Brittany Sigler. I work in population health product development for CVS, and my background is in public health research and the development of public sector products for health. What I've noticed in my background is there's a disconnect between what's happening in the private sector versus what's happening in the public sector, and also the expertise that's available in both. I think it's fantastic that your fairness framework is open source, but that's not necessarily enough for it to be leveraged by the public sector, because that disconnect of the available resources, the population who need them, and the people who know how to use them and deploy them. And often where companies like IBM are partnering or testing their proofs of concept are the affluent academic medical centers. And those aren't necessarily the healthcare systems where there are the populations who can most benefit, where you see those disparities in outcomes. So I'm curious, kind of twofold, and then I have a separate question after. I'm curious, how are companies of your echelon working to bridge that divide? Because your technology, that everything you're saying is very on point. I think there's so much potential to bridge these gaps we were hearing about in our first talk today. But what about the individuals at those small community health centers, the ones where there aren't CIOs, where there isn't someone who knows how to evaluate for fairness or bias mitigation, and maybe people are hearing those words for the very first time today? How can you have an informed conversation Or what do you even do if you can't afford to deploy this in the first place, if they're not even going to benefit from those models? Like, what are the first steps there?
You're right, absolutely. And I personally have been working with public health. We've had a team of folks in Rhode Island on the ground with them, shoulder to shoulder, helping respond to COVID pandemic. And now we're their partner for public health data and analytics modernization. And you're right, there are big challenges. And IBM is a corporation, it's a for-profit corporation, and so yes, we're going to be oriented in that way. That said, there are some super exciting developments in this technology, that there's a nexus between machine learning and generative AI that is really going to democratize this technology, and it's not going to be just something that expensive, highly paid data scientists and machine learning engineers can do. And I think it's going to open up access to the public sector in ways, and not just the public sector, but the not-for-profit sector in ways that we haven't seen to date.
I would add to that. I think the investments that CMS and the federal agencies are making in, for example, the Health Equity Reform Waiver in New York, or Community Behavioral Health Center expansion, I think as you see some of that money come down, there will be those investments made at the state and local level that will help get those resources in place and get the good benefit out there.
That's great. And my second question, kind of, you were starting to get at it before in your question as well, but the AI models used today, and as you said, they haven't been updated since 2021, and those are the ones accessible to the general public online, and they haven't necessarily been refined. And like, a core tenet of public health program design is implementation science. And even if a program works in a particular population, you saw these fantastic outcomes, you may take it to a totally different environment and you won't see anything close. So there needs to be adaptation, there needs to be dissemination, and then you need to evaluate it again. Can we still claim that this works? And I'm curious, because you have the tools of this AI fairness model, have you considered developing the basis to make that differentiated implementation possible? Like, if your population was primarily non-English speaking, if it was primarily non-white, if you were rural, and what that might mean for how you access healthcare, have you considered, I think it would put IBM in a tremendous spot, also just academically and from a business development perspective. If you are the experts, that you know what it looks like to deploy in these different populations and you know that it works, you're going to be who everyone in the public sector turns to. So have you considered approaching that?
We have, and a lot of the tools and the framework that I described to you today has a very flexible, highly configurable definition of what we mean by privileged and unprivileged. In some contexts, that's about white, not white, and other groups. Just like you say, in other contexts, it's the difference between urban and rural. In other contexts, it's the difference between more educated and less educated. And so the framework that's been developed is very flexible in that regard. And so I think, yeah, that's one of the strengths of the framework that I described.
I think the other piece, and Mark, you can expand on this, is just as you work with specific use cases or specific applications, being able to expand the data the model we're trained on with curated data from that environment. That's what we do with our own customers, right, is bring in as much of that rich, unique data to help advance to that next step.
Thank you, and thank you for your time.
Hi, my name is Lewis. I'm from St. John's Hospital in Yonkers. I have sort of a more technical question and then a social aspect of the same thing. So one of my big curiosities, I do really enjoy learning about AI and ML. And I wonder, as we grow in our capability to process the data, it needs to be retrained more and more often through different hospitals of lower technical abilities and stuff like that. How do we continue to maintain safety and privacy as we try to grow the data set to be bigger, to include more specific outcomes and groups, and allow the AI to continue to form those groups and get better?
This is such a great question and something that I'm super excited about. I was at a conference at the CDC last fall where they were talking exactly about this, and there's really interesting advancements in what's called federated machine learning. And what it means is that we can have a common AI machine learning solution, but it's trained on disparate data sets that are maintained locally, privately, securely, and then instead of having to bring all of that personal health information together in a single corpus of data, we're able to distribute the learning across data sets in their source so that we're not having to move them and take security risks and risk that data will be subject to breach and expose folks to privacy. So there are some super exciting developments that allow us to benefit from AI machine learning without having to bring data together in a big giant corpus.
That is awesome to hear. So I have sort of the social aspect of the same question is, as AI becomes more of a buzzword, ML much less, as it's sort of been forgotten by the general public, as these things become more and more populous, how do you feel there's a good way to continually engage with the fact that this is a very politicized thing, especially throughout the country where we're trying to get these data sets to improve in these different areas where they will have different resources and things that will affect the outcomes? How do you feel like you can overcome the politicization of that through a technological or non-technological solution?
If I had the answer to that, I think it's transparency, right? I liked what Mark shared about, designing in fairness. I think it's also then on the ultimate delivery and just being very transparent and open about how models were developed and deployed.
Thank you, guys.
Hi, my name is Cheyenne. I'm with Engagewell IPA. I had a couple of questions. One of them is more specific about the prior authorization thing that you were talking about. I think a lot of us work with care managers who are often on the other side of that. And I was wondering if there's been any analysis of have the percentages changed in either direction for different populations on the amount that are getting approved versus not approved, now that AI is helping speed up the process. So that's one question. And then the other question kind of loops back to the first question that was asked. Sorry, I forgot who asked it, but when we're using AI and we're trying to close disparities, right, and we're trying to close gaps, if we're evaluating it on a fairness metric where things are being treated the same way if someone is in an advantage group versus a disadvantaged group, I think in some ways that makes a lot of sense for prior auths, but how do we, for other examples, how do we use AI to close disparity gaps from an equity perspective where you're closing that gap so not everyone is treated the same? Does that make sense? Thanks.
The first question, I'll take that. I don't have information off the top of my head about that particular client, and so I'm not going to be able to answer that today. But did you want to take the second question?
Could you repeat the second question? I'm sorry to make you have to say it again, but if you could just...
Yeah, so the question is, if we're trying to close disparity gaps and everyone is kind of being treated equally by AI, how do we close the gap? Because wouldn't that maintain the gap? So the question is kind of like, how do we use AI? I mean, I think it can be very helpful to identify disparities, but how do we use AI incorporated into tools to close disparities?
Well, I think some of it's about the insights you gain from that in terms of what the real issues are and how they can be addressed. It's through experimentation, to see, try, as I think we heard from the previous speakers today, right? Put some pilots out there, see what you learn, and measure. I think the PA study, neither Mark nor I have statistics on that, but it was designed to be monitoring as you go, as Mark said, very important to do so. There have been some horrible abuses out there of prior authorization, and it's in the news every day now about how it can be.
Is diversity and equity, and I've got to tell you, I've worked 30 years in machine learning and artificial intelligence, and I've been with IBM since 2015, and I've never worked with more diverse teams of consultants and technologists than I have with IBM. And it enables us, I think it's one of our strengths, it enables us to engage a lot of different kinds of clients. And so thanks for the question, and it gives us a chance to toot our horn a little bit about that.
I guess as I'm sitting here thinking through, sort of what you just said about misuse and a lot of the questions from folks, I guess I just want to acknowledge that there's bad actors. Many of them, from little people like scammers to like bigger companies and insurance companies and CBMs and people who are not trying to advance equity, people who are very privileged and happy to see the structural inequities as they are. And I think it's wonderful that all of us are in this room talking about this because we don't hear about it enough. But I'm wondering, what kind of lights are being shined on the structural inequities that are only being sort of more entrenched as more data is collected and more is known and more patterns are seen. I'm thinking about just not wanting to go get BRCA testing, for example, because I know that could jeopardize my insurance coverage in the future or my life insurance coverage in the future. And I think that those things are real. So I wonder if you have anything to say about that.
I think I have this analogy, right, of AI will help monitor itself almost, right? I mean, we've got applications out there that detect fraud and abuse in the insurance industry, right? It's very similar here in terms of real-time looking to detect are there misapplications. I think it's kind of a new frontier, really, I think, in terms of looking for those patterns. But since that is what AI is so good at, I think it's a question of focus and commitment to doing that, to weed out those misuses in every way.
I think it also, like in any area of commerce and social interaction since the beginning of civilization, it speaks to a super important role for government regulation so that those bad actors can't act without consequence and without restraint.
That means vote, everybody.
Thank you. That was my question. What are your thoughts on regulation? When you talk about the financial industry, it's very specific. When you talk about healthcare, it depends. We were talking earlier about a small agency that had a security breach, but they had systems in place to try to prevent their healthcare information being stolen, but it was stolen. And the bottom line is, how do you know? What are the bare basics on setting up systems so that you don't get a breach in your security? I'm not quite sure if there's anything out there, but what are your thoughts on setting up a regulatory system in terms of AI, in terms of this type of, preventing bias and so on and so forth?
Well, there's already at both the national and the state level, right, guardrails that folks are trying to put in, particularly, since generative AI has emerged and all of the sort of unique risks with that around hallucinations and other things. So I think some of that is inevitable to make sure we're all playing by the same rules, right? And that there's, some authority brought to bear to, for that kind of oversight, really some senior attention to what is needed to monitor, and I think we're all in the process of working through that now. I don't know, Mark, from a technical perspective.
Well, I think I'm biased from my point of view, and I won't even pretend to speak for IBM, but I think the trustworthy AI framework has a lot of good practices that might be a good source of the kinds of regulatory framework that could help make sure that AI machine learning solutions that are perpetuating bias never get to the marketplace.
Good afternoon. I appreciate that you both came and spoke about the work that you've been doing so far. I think something that's been going through my head as I've been listening to the questions of other participants in this conference is really this idea that I think there are two levels of inequities that we're really seeing in our field. One is even this idea that, as a, not sure like what is the setup at IBM, but even this challenge to IBM to say like that equality piece, I think needs to be massaged further, because actually the idea is that we want to resource more of those disadvantaged groups so that, I know, Mark, you were talking about like you want to give expedited access to communities that have been underserved and marginalized. I think that even that needs to reflect even in the team of like IBM, right? And so talking about like what is the systems that have been put in place to talk about like the DEI process and like how that will come out in the work of the projects that y'all are doing. So I think even posing it as a challenge, I think, to IBM to do that further work, and dig in deeper. I think the second piece that I'm reflecting on, I think for the whole of like the conference, is that I think that, we were having conversations earlier about how the financial sector is like years and decades ahead of us in terms of the work of tech, right? And how now as nonprofit organizations, smaller organizations, we are left to sort of grapple with like the impact of tech on our communities, not just like in the differential access or the bad actors, but even the fact that like our organizations ourselves may not have those resources in order for us to equip ourselves. And like, so therefore, where is the, who needs to be accountable to that, right? Who needs to step up and make sure that our communities are being served and we have partnerships that are able to respond to that? Because, I think some of us are thinking, is it always going to be on the community-based organizations and nonprofits that have to shoulder that and step up to the plate to be able to address these gaps? So I think part of just a reflection and a thought is like what type of partnerships are available? Who is going to be able to say to big tech companies, you're accountable to like the people whose data you're using, whose like money you're using for your whatever tax, cuts in your company. I think I think it's also another really big and broad question, but just reflecting on that and seeing like where can AIDS Institute and these organizations, do we form like a committee in order for us to be able to like address some of these like advocacy points? Yeah, just thoughts.
Appreciate the reflections, the very deep reflections. I think those are observations we'll definitely take back.
All right. Thank you all for your very engaging, and sorry for the firing squad up here, guys. We appreciate you addressing all those questions. I'll quickly give you my best definition for the itis, just so you don't leave here ignorant. So it's that lethargic or sleepy feeling you have after you eat. It's derived from slave masters speaking to their slaves. It's called the niggeritis. It's been abbreviated and sort of embraced by our community as just a thing that happens. And so that's why some folks will raise their hands and some won't. So yeah, that's that. Probably a term you didn't think you'd hear at a digital health conference today, but you're welcome. Thank you so much for your time. We appreciate your questions. All right, so before we send you off to network and eat after you network, we want to do a little announcement about a very successful program that we've had here at the Digital Health Initiative. I don't think I ever introduced myself. I'm Mark Thompson. I'm a member of the Digital Health Initiative. That's me. If we could put those slides up, we'll be here in 1 second, and then I'll talk some more. How about these speakers, right? We've had some pretty... Okay, so the project that we've been working on since 2015? 2015. It's called the Why Get It Project. It's comprised of a mobile application that video should be going, but it's not. That's okay. These things happen. It's a tech conference. The app is designed to facilitate care, to pass on health information. It's being used across a number of different organizations. It was originally developed to help folks who are living with HIV stay in care. You can text through it with your healthcare provider. We put health information in a bunch of different social media-esque formats, so short video, little blurbs. All of the care team information is there, so when you lose your papers that they give you when they leave the doctor, or you can't remember your doctor's name, that's all there. You're able to email or text right out of the app, and we saw an increase in viral load suppression among users when we did a study on it. It ended in 2018? Thank you. You clap more, it's okay. And our graphic serial comic, which is called Tested. Next slide. I have a clicker. All right. All right, there's our slide. All right, so Tested. Tested, again, is our graphic serial comic. It features a diverse cast of characters. We are fortunate enough to have one of our writers in the audience. Sheena, stand up, please. Thank you. So she's being modest, but that's Dr. Sheena Howard. She's an accomplished academia. She is a doctor at Rider University, a professor. She is the first black woman to win an Eisner Award, which is like the Oscars of comics. So again, amazing person. We also have another writer named Josh Billig, who is unable to be here today, but he has a number of Netflix shows. He's written plays. He's been a professor at NYU. We've gone through 3 different artists, and that'll be reflected in the artistic styles that you'll see in the comic. But you can see how diverse the faces are. Something we really talked about and has come up during this conference is the importance of representation. People need to see themselves and their experiences in whatever we're trying to do related to health, because the information comes second to the connection that you make. And so we tried to do that through our comic. Next slide, please. All right. Because we've done that, it's been extremely impactful. We've had over 1 million views of this comic. This is a public health comic, right? So we've made lots of great relationships with digital platforms. We have 1 million of those views alone on Webtoons, which is the world's largest online comic forum. The majority of their folks are under the age of 25, so we're hitting a market that we really want to hit. In that space, we've been able to create a community. So we have about 17,000 followers, and people ask questions. They talk about their own personal experiences. We're able to connect them to health information and resources from credible sources. We're not practicing medicine, obviously, because it's like an open forum and all that, but we hit people in the fields. You can see that people want to cry happy tears after they read it. And making an emotional connection when conveying health information, again, is how things stick. And so we've tried really, really hard. So we make you laugh, we make you cry. We do all the things to evoke a feeling, and then information is retained a lot more effectively. What's also great is we developed a community within the comic, especially on Webtoons. So we'll put something up, let's say, about a person of trans experience, and there will be one or two people always jump in and say something awful and terrible. It is part of being on a social platform. What's great is that 80 to 90 people will jump in and call that person terrible and connect you to resources and support whoever else is on this platform commenting and trying to get that information. And you guys are in luck because, next slide, please. We have a new season launching today. If you go out to our table there, you've seen the comics when you walk in. You can scan the QR code, you can read it online. This one is heavy about self-identifying. It covers HIV and AIDS, covers stigma, covers all the different things that people deal with in life, far more than those two previously mentioned subjects, which is why people are engaging. And we're very excited to bring it to you. Next slide, please. Oh, hold on, don't go slide. Oh, I'm in control of this, I keep forgetting. Another great thing is that we were recently funded to have 5 more seasons of Tested, where we have 8, so thank you again. I won't stop you from clapping if you want to keep doing that, that's fine. And we're touching on a lot of different topics. So we're going to be doing a long COVID season. It's a thing that's affecting a lot of people that really isn't getting the information and the exposure that it needs to, because people's lives have been drastically changed by this. We're doing mental health, and all of these things intersect with HIV and AIDS, which again is at our core for the AIDS Institute, as well as substance use disorder, domestic violence. We cover a lot. It's a very cool comic. So if I didn't convince you already, please go out and read it. And I think that's it, yeah? Oh, sorry. And yeah, we're here, so again, go network. Lunch is coming, it should be out there. When you are speaking to each other, speak from a place of implementation. You know, say what you do, say who you are, and think about how do we do something together. That's the reason for these conferences. We can sit up here and tell you all the stuff, and that's great and wonderful, but you're meeting people that you wouldn't meet in other circumstances. And so please capitalize on that. Reach out to us. We're happy to help facilitate that as well. And all right, that's enough talking. Go and have a great time. Oh, and look at the posters. We have posters. There are 4 of them. Check them out. All right. Lunch starts at 12, so talk hungry for 20 minutes.
Okay, because he's not here.
Thank you all for coming on back. Please accept our apologies for the fairly abbreviated lunch, but you ate, so we're happy. So that we don't all get the itis, I'm gonna throw it out there again. We're gonna be doing a guided meditation through Gillian Bell. She is the founder and director of the Urban Yoga Foundation, and she's amazing. And so please sit back and relax, but not too much, and enjoy.
Thank you. Thank you. Welcome. Find your place seated as you are. Feel your feet on the ground beneath you. And remember who you are. Place your hands maybe on your thighs or palms together raised. And soften your body. Either close the eyes or bring the gaze low until a crease of light shines. But notice your breathing body. And soften. And feel the breath. Listen. Healing has a frequency of sound. Listen to your body and soften the feet beneath you. Listen. Bodies. You are wind and water. You are earth and sky, sun and moon. The nature of all things. Breathe. Soften. Relax the calves and knees. Feel the softened thighs and release the hips and buttocks. Go deeper. Body. And remember who you are. The healing is in your hands. Soften them. Soften, soften. Listen. Listen to your body. Release the belly, let it hang. Soften spine. Feel the arms draw down side body and notice the body. Sacred beings. Relax the throat and jaw. Feel the hollowed cheeks and softened nose. Listen. Breathe. Bodies. And soften yourselves. Clear your mind. And notice the body mind. This is the union that is yoga. Soften like a warm candle, melted wax, like butter on the stove, like chocolate in the sun. Feel the water beneath your feet and what has come before you being here now. Listen. And breathe. Slow inhale through the top of the breath through the nose and pause. And as you exhale, soften your body. You are water. You are earth and sky, sun and moon, humanity, colors of our people. Remember who you are. Remember the healing in your hands, the beating of your heart, the sound of wind as breath. And honor your body. Inhale, lift the shoulders high, raised, roll them back, opened heart. Soften spine. I will ask you to stand on your feet slowly, if you are able, and bring your palms together and rub them as fingers are raised. Feel the heat in the hands. Rub them with friction and intention. The body doesn't know it's not running. The breath is moving. Feel the body, the moving breath, the beauty of the breathing body. Stop and bring the hands together. Don't let them touch. And feel the energy between your healing hands. Rub them on the sternum, the collarbone, emptying out the lymph nodes as we do lymphatic drainage. Breathe. Bring your hands to your neck and make a J. Just bring down the energy in the neck and come again towards the collarbones. Starting at the earlobes, feeling and drawing down this lymphatic energy, our plumbing system. Breathe. Tap the shoulders. Beautiful. Right here on the hips. Breathe. Side on the belly. Lymphatic drainage, important for the body system. Right here in the crease of the arms. Other arm. Underarm, the yin side. Breathe, bodies. Other arm. Feel the slight bend in the knee, behind the knees. Inhale, arms up. Feel the stretch. Bring the palms together, look at thumbs. Reverse the hands. Bent elbows, palms all around the body. Find yourself seated. Again, feel the feet on the floor as we close our practice. softening ankles and calves. Notice the body's rhythm, the gentle beating of the heart. The gentle softness in your legs. The gentle ease of your breath. Breathe. And remember who you are. Release the hips and buttocks. Feel the body sink. Soften. And listen, listen, listen. You are nature within nature. Remember who you are. Inhale to the top of the breath and pause. Exhale, audible sound. 2 more times. Inhale to the top of the breath through the nose. Pause. Exhale, open mouth, audible. Once more. Inhale, breathe. Exhale. Thank you. Thank you. Thank you.
Thank you. You somehow simultaneously soothed and invigorated me. I didn't know that was possible, so I appreciate that. Thank you. We give a round of applause for Gillian Bell. We'll just take a moment to reset the stage back up. And so stay invigorated and soothed, and we'll start momentarily. All right. Harlem Center music means we're right back at it. So, yeah. So for our third session, we will be bringing on 3 different speakers. This session is entitled Applying Digital Tools to Current Health Care Systems. So we learned about what they are, and now we're going to talk about how they're going to be applied. We have 3, again, great speakers. The first of which is Kamal Bajaj, Dr. Kamal Bajaj. She's the Chief Equity Officer at New York City Health and Hospitals and Jacobi Medical Center. She will be presenting about healthcare quality and safety functions to promote digital equity. We also have Dr. Natalie Pagler, we'll go with Pagler. And she's a Chief Medical Information Officer at Stanford Children's Hospital. She came all the way out here from California for us. And she'll be talking about health in the digital age, empowering children, adolescents, and families. And we have Dr. David Berger, and he is the Executive Officer of SUNY University Medical Hospital at Downstate, and he will be discussing a framework for evaluating digital health tools. So we'll ask Dr. Bajaj to come on up.
Such a zen-full session, and I agree with you. I'm zen and invigorated at the same time. What a delight to be with all of you today, this sort of diverse perspectives on what is a crucial topic to promote digital equity. As was mentioned, my name is Komal. I'm the Chief Quality Officer for a couple of hospitals in New York City and the Bronx that are part of the municipal health system, and I'm an OBGYN. And so my comments are sort of framed from that perspective. I will be mentioning a few resources that come from the AHRQ and the National Academies, and so I just wanted to mention sort of my affiliations with those organizations. There are no financial sort of relevancy, but I thought I'd mention that. So just a word about health and hospitals. It's the largest integrated municipal health system in the United States. Here's a map of where we are. I spent a lot of time in the Bronx. We have 10 acute care sites, a whole host of clinics, post-acute long-term care. We have our own insurance plan. And so my comments are really thinking about how do quality and safety functions promote health equity. And we've learned a lot over the last several years implementing this work across a very large health system. So we are privileged to care for amongst the most diverse communities in the world. Here is a screenshot from our community health needs assessment. And you can sort of see the breakdown of our patients here. And one of the things that I'll mention right off the bat is that each health entity has to have a community health needs assessment, sort of part of sort of requirements to have one. And different organizations will take it different levels of seriousness. We take ours very seriously, and so I just sort of want to honor and mention that that's a really lovely source of information on, what is the makeup of who we care for and also what matters to them. So our mission is really second to none, to deliver high quality care with compassion and dignity without exception, and all of what we do is underpinned by racial and social equity. And so, when I talk about quality and safety functions and structures, right, which whether you're a tiny clinic in a rural area or whether you're a very large academic center, there are people who are tasked with doing quality and safety work. You really have to think about, well, what is quality healthcare, right? If we sort of close our eyes, we can all kind of think about what that means to you, right? According to the National Academies, it has sort of 6 main features. It's safe, it's timely and accessible, it's effective, it's person or patient-centered, it's efficient, get what you need when you need it, and it's equitable, right? And so as we think about digital health equity, certainly quality and safety functions are well positioned to help advance this important work. I also want to highlight the Agency for Healthcare Research and Quality, which is one of the HHS agencies, recently put out a digital healthcare equity framework. We've heard about a lot of amazing frameworks today. And what I want to point out is that the equity domains center around patient and community characteristics, which I'll talk about in a bit, health system characteristics, which include access and quality, and our IT, which we heard a lot about earlier today. And I want to mention, I'll share some examples of advancing health equity using quality and safety functions. I'd like to say that we've got it figured out when it comes to digital health equity, but we don't, right? And so we're starting to see some of the seedlings of impact, and if we have the same conversation a year from now, I imagine we'll see more robust examples of digital health equity and quality and safety functions. So the first sort of core function I'd like to talk about is regulatory and accreditation. Everyone shivers a little when we say Joint Commission and other sort of regulatory agencies, but I want to highlight that there are some recently revised requirements to reduce healthcare disparities. And I'd press on all of you in the diverse perspectives that you come from, whether you're consuming digital technology, whether you're implementing digital technology, think about how what you're building, what you're creating, what you're implementing can help meet these standards, because that's a win-win, right? And so this comes directly from the Joint Commission, that they designated an individual to lead activities to reduce health disparities. That's structural change, right? That's investment. Assess patient health-related social needs and provide information about resources that are available. Stratify quality and safety data using socio-demographic characteristics. Develop a written plan to address at least one healthcare disparity. Love to see in the future that digital equity is the target. And inform key stakeholders about the progress, right? And key stakeholders are patients, communities, healthcare teams, along with sort of key apex decision makers. The second is to really think about quality assurance and data and analytics. We heard earlier about NYU's journey, right, to build dashboards around measurement. Also heard that with some of our other speakers as well. I want to highlight two key areas that every health delivery entity is needing to do something about, and how you can harness that. The first is to advance social determinants of health screening and improve data integrity. So beginning earlier this year, all admitted patients must be screened for 5 domains: food insecurity, housing instability, transportation needs, utility difficulties, which things like internet and access might be a part of, and interpersonal safety. Now, CMS doesn't say you have to do it a specific way, right, how you ask those questions, but at the end they ask how many people were screened and what percentages were screened positive. Ultimately, we anticipate that there will be sort of additional layers on what did you do about it, right? What did you do about it? So this is our early experience at New York City Health and Hospitals. 35,000 plus patients who were admitted, 82% screening. We're working on sort of getting that up to 100, right? But sort of the structures take time to build. And here you can see the breakdown of transportation, food insecurity, housing quality, right? Housing insecurity, and interpersonal safety. Of the patients that screened positive, 15% screened positive for more than one, right? More than one. And so here is a really important source of information when designing and implementing solutions, right? Because these individuals, right, we need to make sure that when there's a digital solution that's put in place, they are able to access the benefits. I also want to mention that, there's been a lot of focus on acquiring or sort of asking folks for their sociodemographic information, right? Lots of folks, rightfully so, are building algorithms, making decisions about resource allocation based on the demographics of the populations they serve. And so we realize that it's one factor to have complete data, but it's another thing to make sure that it's accurate and relevant, right? And so these dimensions of valid data come from this excellent resource here, a framework for stratifying race, ethnicity, and language data. And it describes accuracy, completeness, timeliness, and consistency, right? So 4 key components. I happen to chair the Equity and Access Council's Monitoring and Evaluation Committee for this work. So what have we done so far? We updated the data field so to try to improve consistency so that one part of the system, one area, that we're all kind of asking and thinking about information and rolling up information the same way. We aligned what we're doing according to the New York City OMB categories. We also standardized ethnic groups. We added a hard stop so that when someone enters our system, we ask the questions, right? And they could enter our system physically or digitally. And we expanded ethnic background. In 2021, again, we sort of ratified these definitions across our health system. We continued to make patient-centered, friendly ways of getting this information through kiosks and the patient portal, as was mentioned. And we continue to evolve to meet sort of our new learnings, and in this case, sort of adding a new Middle Eastern OMB grouping. So our goal is to stratify all quality measures by complete and accurate real data. Talk about other data in a minute. And so here you can see these are our hypertension control rates, right? And you can see that there's variability, right? We don't know where the variability is and where we need to put resources unless we begin to look for it, right? And so here you can see the completeness. I want to have you look at the yellow and the sort of the darker blue. You can see that in 2022, the percentage unknown or something else was actually quite a lot, right? And you can see now that in April of 2024, we've begun to shrink that number. We don't anticipate ever getting to zero, because if someone doesn't want to tell us, great, fine, thank you, right? But we need to make sure that we're asking the questions in the most person-centered way to get as many folks who are willing to share. We also are embarking upon a project to survey patients through the Institute of Healthcare Improvement guidelines. We're basically sampling and asking a patient, we see that you're listed as here, this, and this, and this. Does that make sense, right? Is that accurate? And so based on those small samples, we will likely have additional sort of tests of change to improve accuracy and completeness. As we're learning more about real data, race, ethnicity, and language data, we are extending this sort of process of standard groupings to different kinds of demographic data as well. The third is performance improvement. And, lots of people improve things in hospitals, in clinics, in telemedicine type services, and we encourage everyone to apply an equity lens to the work that they're doing. So just as a reminder, again, the Community Health Needs Assessment. The Community Health Needs Assessment tells us what are the top priorities according to the community. As a Chief Quality Officer, I take that very, very seriously, right? As we're making decisions on, we can't work on everything, what should we work on? I also want to talk specifically about an equity lens, and I wish I could say digital health equity lens. We'll get there, right? We'll get there. But this is a proactive approach for improvement work, and the reason being is that projects done without an equity lens can worsen or perpetuate disparities. We saw a little bit of this in the design process of algorithms. So this is our balanced scorecard. Every year, we ask departments and committees to prioritize what are the 5 things you're going to work on, right? And align them according to our strategic pillars. We ask that an equity lens be added to each of those projects, right? So not only what is the project that you're going to work on, what could be a potential structural barrier to this project being successful in all the groups that it's targeting? So from the beginning, we're asking in the planning phases. We then, as people are peeling back all the layers and trying to understand why a problem exists, we've added health equity to our cause and effect diagram to provoke teams to really think about structural barriers to care. This is a busy slide that shows how we report projects. And again, I want to add that we've hardwired adding stratified data by that equity lens into our reporting. And not just that, don't just stratify it, tell us about it. Why did you take on this equity lens? There were lots of things you could think about. Why this one, and what'd you find? So this is an example of why equity lenses from planning to implementation to monitoring matter. Right, so if we were looking at this is a real project, we were looking at a feature within the MyChart utilization. And if you saw this graph, you'd be like, high fives, pizza party, score, amazing, awesome work, right? Until you look at the data by non-English language preference, right? And so you see here that there were certain groups that were targeted that didn't experience the similar gains. Now, we wouldn't have known these things until we went to go look. And at first, I will tell you, there's a little bit of like guilt and shame. But what we've really said, and we've tried to build the culture, is You found it, now we can do something about it, right? Do additional tests of change to close that gap, right? So that everyone targeted experiences similar or better gains. Knowing that this was a work in progress and that as we were grappling with this, so was the rest of the community of practice of quality and safety practitioners, we wrote about it, right? Like we wrote about it. Here's what we know so far. And so what we asked and what we really wrote about was, how do you ingrain equity into every step of improvement, from identifying the issue to the aim to thinking about the current state? So, what populations are being targeted? Does the team feel comfortable discussing bias and inequities, and how will the patient's voice be incorporated? So we use this as a discussion guide during planning. Are the targeted populations clearly articulated? Does the time frame meet patient needs? And what bias exists in existing data sets? What inequities already exist? And how will we mitigate bias during data collection? Will the tests of change impact those most vulnerable? And are materials readily available in the formats and languages that are necessary? Learn from the tests of change. Were there any intervention-generated disparities? And this is a key one for us. Do the targeted populations believe the outcome? And that has been like a very humbling, honestly, important conversation. What are potential structural barriers to spread, and how do we share? And we like to share even if we don't hit the mark, because there's a lot to learn even when we don't hit the mark. So here you can see across our health system, we had 459 projects over the course of 2 years that had an equity lens. Not shockingly, language, age, gender, race, and ethnicity comprised the top 5 lenses that were sort of identified and applied. And what I think is really fascinating, 81 of those projects, of which language comprised the majority and it's followed by race and age, 18% had an intervention-generated disparity. So 1 in 5 projects, despite our best intentions, we saw if we split the data, there was a gap, right? So even great outcomes, right? High five each other, you need to look, because in 1 in 5 cases, there will be an intervention-generated disparity. We think this is so important that this, the number of PI projects submitted to the board with an equity lens is part of our strategic dashboard to the board. Patient safety, building systems for both patients and staff to tell us about barriers to equitable care. Again, barriers to digital equitable care. So this is a screen grab of our occurrence reporting system. I'm going to zoom in a minute. But every organization has some way that they use for frontline staff and for patients to tell people what's wrong or things that they're seeing, right? And so here we ask the question, did potential bias or structural inequities contribute to the case, whatever they're reporting, right? And we have had all kinds of things come into this box. It's intentionally sort of open-ended. And I'll tell you, I went and re-looked, and there are some digital health-related things that come up. When it comes to care experience, we started to look using some of our advanced technologies, near-time analysis of social media posts, and we apply an equity lens when a patient formally places a complaint against our organization to really look at, did structural bias or inequity play a role in what this patient is telling us? How did it? The last is to really think about event analysis. Every organization, again, very, very tiny to very, very large, has some mechanism by which they review events. And how does bias and inequity play a role? The first we've really paid attention to is our culture of safety and sort of promoting psychological safety. These are hard conversations. It's hard for someone to admit, my biases played a role here, or our organization is set up in such a way that it doesn't promote whatever we're trying to achieve. We also gathered more information during the case. I'll tell you, 10 years ago, we weren't collecting a lot of this demographic type of information. We also probe our staff about barriers to care, ask what were the obstacles to equitable care? How did time of day or day of week contribute? And we specifically ask, was there adequate access to language translation services? And we've made a lot of investments and changes as a result. Again, we've also included equity in the fishbone when we're reviewing these cases and ask, were there any potential sources of structural inequities and bias in this case? You know, like, again, we like to sort of think about things and also then write and share our experience, not because we have it all figured out, but because then other people tell us how to do it better. And so we developed this wheel which sort of talks about internal factors, external factors, and organizational factors. And this is a worksheet that we use during event analysis, and it was actually recently published by the Joint Commission last week, actually. So again, centering it back on our humanity, the humanity, and who we serve, right? We have the fortune of being in one of the most diverse cities in the world, caring for the most diverse populations in the world. I hope that, you know, what I've shared with you today and our work to advance health equity a year from now, even less, could really sort of zoom in on digital health equity. I am fully confident that as we continue to learn, as we continue to adopt these tools, learn about these tools, that we will zoom in on, you know, how do core quality and safety functions promote digital health equity? You know, and I, you know, we as a community of practice, I'm looking across this room, right? We can and we must do better. And certainly thinking about how do quality and safety functions, those things that are already happening anyway, promote digital health equity, are one important way of doing just that. I thank you for your time. Connect with me on LinkedIn.
Do you want me to sit here or downstairs?
Thanks.
That was an excellent presentation. Thank you, Dr. Bajaj. Natalie, Dr. Paisley, thank you for coming up. Paisley. All right.
Thank you, and thank you, Gillian, for calming me down before a talk. I think I need that every single talk from now on. But I'm super excited to talk with you today. I'm Natalie Pagler. I am the Chief Health Informatics Officer at Stanford Children's Health and a pediatric intensivist. And I'm going to talk about health equity through the lens of children, teens, and their families. Here's my learning objectives, and basically I'm going to try to give you a very quick rundown of about 15 years of work by multiple teams in our organization and across the country, but just want to give you a flavor for some of the disparities that are induced by our information systems because they may not necessarily be set up for children and families. I'm going to start with showing this program, and this is about all you get to see about this program. It is an incredible virtual HIV PrEP program that is run by several of our pediatricians at Stanford Children's. There's the link there, and you can look up Jeff, Carrie, or Megan and see their published literature. But I'm using this to tell a story of Robert, who is a 17-year-old that is seen in our system. And he made what he thought was a confidential appointment through what he thought was a confidential portal account for HIV PrEP. Unfortunately, a couple days later, we received a phone call from his father to our scheduling desk saying, hey, there's an error with the portal, something's wrong, there's this weird appointment that I don't recognize for my son. Now, our very quick thinking schedulers were able to cover that up and apologize for the mistake and smooth everything over in that case. But it highlighted the issue of what's going on with our confidential care for adolescents. I'll take a step back and say that in general, whenever possible, we want to engage the entire family in the care of a child, and that's what we encourage. But there are cases where, for the safety of the child or their perceived safety and security and willingness to speak to our providers, they need to feel like they have confidential care. So with that story in mind, let's take a step back and look at the context of adolescent confidentiality. So many people don't realize that patients have had a right to their medical records, a copy of their medical records, since when? Since HIPAA. So for more than a couple decades, patients have had a right to their medical records. But in the last few years, a law called the 21st Century Cures Act Final Rule brought this into kind of more prominent view, because what this rule did was say that patients not only have a right to their medical record, but they have a right to an electronic copy immediately. So how many people have looked through their patient portal to see their labs, their notes, anything like that? Okay, so everybody's using that. How many people did that 3 years ago? A few, okay. So there's a great program called Open Notes that has been trying to do this for several decades, but this law is what really made it much more accessible through the patient portal. So when you take a step back and think about those laws and what they've done for us, you need to contrast it or think about how does that apply to teens. And it becomes very complicated. So the 21st Century Cures Act defers to HIPAA, and HIPAA defers to state laws. So basically, HIPAA says that, in general, a parent of a child has a right to all of their medical data, except for 3 cases. One, where the minor is obtaining care at the direction of the court. 2, where the parent says that it's okay for the teen and the provider to have a confidential relationship. And 3, and this is where it gets tricky, is when the minor has consented for that care and the consent of the parent is not required by state or other applicable law. So HIPAA and 21st Century Cures defer to the state laws. And the great thing about this country is that it's completely equitable and even and the same across all of our states. Right? Yeah? Yeah, exactly. So not at all. And so all 50 states and DC have incredible variability in what these state laws say. I feel lucky that I'm in California, and New York is very similar, where teens have very robust confidentiality laws or consent laws. And so they can consent to things like sexually transmitted disease treatment, pregnancy prevention, mental health care, substance abuse, without the consent of their parent. Again, as a pediatrician, if we can get the family involved, that's what we want. But if that teen needs confidentiality in order to seek that care safely and meaningfully, that's what we need to provide. Now, there's all kinds of information showing that, that having this information sharing, this open access for both children and their families can be really helpful. So in pediatrics, and this is a paper by Chetan Sarabu, one of our clinical informatics fellows, you can help multiple caretakers stay on the same page when you've got a mother, a father, a guardian, a grandmother. It can empower the family to help coordinate care for children with multiple clinicians, and I'll show you a powerful example of that in a second. And it can help teens take more control over their care and start learning about their care. So this is a statement by one of our parents when they first got exposed to note sharing. And I'll just read it because they did such a great job kind of explaining the power here. So, open notes are amazing. I wish all my son's specialists did this. It has allowed his primary care physician to understand his case better, allowed me to print out neurology reports for his school for IEP testing purposes, and to refer back to our previous care decisions, which change often with a medically complicated child. Honestly, my son's disorder is so rare and complicated, we are often the experts educating other doctors. And so having access to everything makes it far easier for me to provide the full context to each new physician we meet, and there are a lot of them. I really wish that more doctors use these open notes. So that speaks to the power of engaging a child and their family in their care, and that's what we're trying to achieve. But of course, we balance that with this need to protect adolescent confidentiality for those teens that really need that confidential relationship. So we try to separate out the sensitive health information from the non-sensitive health information. Super easy to do. Okay, there's a few informaticists in here. So really, really, really hard to do. And if you start looking at where is the sensitive information, it's everywhere, right? It's appointments, it's problem lists, it's medications, it's in the STI lab test, it's in the HPV vaccine, it's definitely in the notes, and then don't forget about the bill that goes to the parent afterwards if you don't have an alternate arrangement. So it gets really, really tricky, and this is the work that my team has been working on, like I said, for 15 years, trying to figure out how do we separate all of that? How do we label the sensitive labs? How do we create confidential notes in confidential teen portals? How do we teach every one of our providers what should go into a regular note and what should go into a confidential note? And again, all kinds of work on this that we can share in more detail. So we did all that work. We created these confidential portals for teens. We created these confidential appointments. Whoops. Oops. And then oops, right? Then what happened? What happened to Robert after all of that work? So with that case, we went and looked at his portal and saw that his portal was connected to his mother's email address. And that when you looked at the messages between Robert and the provider, it said things like, "My son needs this new medication," right? Something's wrong there. Clearly, it wasn't being managed by Robert. And so we partnered with friends at Rady Children's and at Nationwide Children's, and we used a natural language processing algorithm to look at the notes between supposed teens and their providers. And just looking at the notes, and this is way underestimating the scale of this problem, found that more than half of those supposed confidential teen accounts set up at children's health systems were being inappropriately accessed and managed by the guardians. Yikes, right? And when you talk to providers, many people suspected this or knew this, but this finally gave us the data to show how big this problem was. So we first implemented a check and balance. We went upstream and started trying to fix the problem by creating these guardrails to look and see wherever the email address of the patient matched the email address of the parent, or the phone number simultaneously. And we went back and we contacted all of them. We shut down all of the portal accounts that were clearly compromised, and we worked with the parents and the teens to set up the individual accounts. So we want the teen to have their account, and we want the parents and guardians to have their account. And we did all this work, and then we know, again, we have a great team and we're very well resourced, but we know that this is a problem across the country. So we partnered with our vendor and got them to put these guardrails into the foundation system. So that helps everybody who's theoretically on that vendor, but clearly more work to do, right? Because there's other EHRs out there. So we also publish this and we're trying to share this information. And so that helps kind of fix it on the back end, but what caused it in the first place? It comes back to something incredibly mundane, as mundane as contact information. So it may surprise you to hear this. As ubiquitous as mobile cell phones are these days, most babies still don't come out of the womb with one. Well, is that your experience? Not yet coming out of the womb? Okay, just double checking. They also don't come out with email addresses. And yet the first thing that we do when they are born is we register them and we put baby's first name, baby's last name, baby's address, baby's cell phone number, baby's email address. Wait a minute. So what do? Whoever's standing there and gives us their information, we start filling that in, and you have no idea whose it is. You don't know if it's mom's, dad's, grandma's, and that information stays there, and it stays there when that child grows into a teenager, and it stays there when their first portal account is set up, connected to the email address. And worse, it stays there when they're 18 years old and 19 years old, and suddenly a provider is calling a 20-year-old to tell them about their chlamydia results, and it's mom answering the phone, right? We are breaking privacy everywhere because of this just EHR design flaw. So what we are doing is breaking the system. This is a mock-up of our new demographics, and it will clearly say the patient's information, and you will no longer be able to put the cell phone or an email address in for any child who is less than 12 years old. And then it will say preferred contact and who they are, and then it will say a secondary preferred contact. And then you can also see, and getting back to some of our conversations about health equity and language, along with those challenges and knowing what those phone numbers and cell phones are, it's also hard to know when it says Spanish, is that mom, dad, baby? And so it will have that clearly labeled as well, so you can reach the right person and speak the right language with them. Again, we know that we're very well resourced and that we're able to do this locally. So we are going to study that and publish that, and then we are partnering again with our vendor partner and having them come and along with us every step of the way, and they are committed to making that change foundation-wide. And then we need a partner from a policy perspective and with other EHRs to get that changed. But it's such a simple, fundamental design flaw that leads to all kinds of challenges in patient engagement and communication. So that's the gist of the story I wanted to give you, but just to kind of whet your appetite for all the different things that need to be done when you're considering how to digitally engage children, teens, and families. This is just a short list of some of the considerations. So I touched on adolescent confidentiality. Again, there's so much else that goes into that. Thinking about those proxy workflows. How do you confirm a guardian relationship? How do you know that somebody legally has guardianship? This was something that became very apparent during the pandemic. Before the pandemic, we literally, if you showed up with a child in clinic, we assumed you had a legal relationship. That's how fundamental it is. And so during the pandemic, we had to set up digital workflows for trying to confirm who is who, but it gets really challenging. There's lots of work coming down the line in terms of digital identity, but that doesn't yet touch children. So again, just a place where children fall a little bit farther behind. If you have confirmed that relationship and you do have it set up with the right person, oftentimes that information may all be coming into one device. So if you're trying to do remote patient monitoring for a child, how do you separate out the data that's coming in for mom's blood pressure monitoring with that of the baby's? It gets really tricky, and we've had some crazy, scary stories that have happened. Children also don't necessarily have devices. So again, when you're thinking about remote monitoring or thinking about cell phones and the babies who don't quite yet get them until they turn 2, they may not have the devices they need for some of the digital engagement. And then becoming ever more prevalent are the issues around child data privacy, and COPPA 2.0 just got proposed, the Children's Online Privacy Protection Act. Highly recommend people pay attention to that story because it has implications for how we share information in health information. And then finally, there's also concerns about inappropriate data sharing, and we've seen all kinds of crazy stories where a parent will post their child's entire genomic data on Twitter. So how do we educate both our teens and their parents about what's appropriate to share and not share and the implications that may have? So again, lots of work to do here. It takes a village. These are a few of the people. We've got an incredible team of informaticists at Stanford Children's, our patient portal team, data scientists, our clinical informatics fellows, our privacy and compliance and regulatory folks are like our best friends because they're constantly helping us to sort out the laws and the rules. And then lots of folks who've already been mentioned today, but the ONC has been a great partner in helping us think through and helping us put some of these guardrails in around teens in particular. The American Academy of Pediatrics, Children's Hospital Association, Open Notes, but it takes lots and lots of work to make sure that we do this right for kids. And that's what I've got. Thank you.
Thank you, Dr. Paisler. How great was that? All of these has been so good. We'd like to invite Dr. Berger up to speak about how we evaluate all these digital health interventions.
So thanks, and I'm not going to tell you anything about evaluating digital health companies. When I looked at the agenda and thought about the audience a little better, I decided probably not the right talk. I really thought the most important thing to do is talk about addressing disparities with digital tools from a hospital CEO perspective. And in my humble opinion, as someone, and I'll tell you a little bit about my hospital, I run University Hospital at Downstate. For those of you who are New Yorkers, you've probably seen that we've been in the news the last several months, and not necessarily for positive things. I run a hospital that 85% of our patients are funded by government payers. 45% of our patients are on Medicaid. Unlike H&H, which has done a marvelous job creating an integrated delivery system, we are not supported by the City of New York, and we are part of the SUNY system, and we're not supported as a hospital, we're supported as an educational platform. So what that means is it's almost impossible to generate a margin. So most institutions, especially if you look in the big ones in Manhattan, generate a margin because they have a large commercial base, usually at least 30 to 40%. So they can offset the loss on the government side. We don't have that. The other place these institutions generate capital from is grateful patients who are very wealthy, who donate to those institutions and put their names on buildings. We don't have that. We have grateful patients. Unfortunately, our grateful patients are not able to help us economically. Why do I say all of this? Is because while digital health, digital tools have been proposed as alleviating healthcare disparities in this country, I think in the short run, what we are seeing and what we will continue to see is an increase in disparities. And I hate to preach to you, but there is only one way we are going to address health disparities in this country, and that's by changing the way we pay for health care. And I'm sorry I'm up here on a high horse and I'm talking to the people who already agree with me, but the reason I'm talking to you and talking about this is because you all have influence in your daily lives, in your careers, in your leadership positions, in your community. You have power. And your power can be used for good in terms of changing our healthcare system and achieving someday, hopefully, healthcare equity. Right now, and the things I'm going to show you, we're putting a Band-Aid on equity. And I give incredible credit to what H&H has done and the system has done. What they're doing with SDOH is just remarkable. What they've achieved as an integrated system is phenomenal. What their work and what they do every day, they should be commended, really. And I commend the leadership of the City of New York for supporting H&H and what they've done. So with that diatribe, I'm going to show you, and one other thing in terms of my diatribe, there are not a lot of digital health companies that want to work with us, right? They just see Medicaid population, a lot of social determinants of health issues. That's not where we want to go in terms of being able to build our companies. So just a recap of the disequity in healthcare in this country. If you look at the impact of the pandemic on life expectancy, especially in black population. I turned it off. There we go. Is there a pointer on here?
Oh, it's the center button.
The center button, thank you. There we go. So if you look at the life expectancy in black Americans, you see it was already below whites, but look, 74.8 versus 78.8. But look at the impact on the pandemic. And again, in Native Americans, even a more dramatic impact. This is what I started out referring to, and if you look at black Americans and Hispanics and who they're funded by in terms of their insurance, compared to white Americans, 75% have private insurance, only 57 or 53% of black and Hispanics have private insurance, and mostly they're funded by Medicaid or they are uninsured. And the uninsured has a lot to do with also the migrant population from South America. And then if you look at the issue of getting access to health care, any lessons here is white, 6% have an issue. It's almost 2/3 more in black populations and even higher difficulty in getting needed care in Hispanic populations. And not only is there gross disparities in access to health care, insurance, life expectancy, et cetera, there's also a significant digital divide. So if you look at the availability of smartphones, desktop computers, home broadband, or all of the above by income, you can see the highest income group in this country, those making over $100,000 or more, have over 90% of them have access to advanced digital tools. While if you look at the lowest socioeconomic groups, they have only 76% have access to smartphones. And an interesting thing we have found with smartphones, which has resulted in a problem in achieving use of digital tools long term, a lot of people in our demographic area who use our hospital, they have smartphones, but most of them are on minutes plans. And by the end of the month, they are out of their minutes. Others have burner phones, and they are constantly turning over their numbers. So the fact that H&H is able to collect that information from such a high percentage, even though you said it's not as high as you'd like it to be, it's a challenge because even though they may give you a cell number, that cell number may not be accurate at the end of the month or a month from now. And again, we talked about and heard about disparities in artificial intelligence because of algorithms, and that is a big problem. So if you look at a simple thing like blood oxygen levels using AI and wearables in patients with darker skin, that has been found to be much more difficult. So when you're rolling out different prevention products or long-term monitoring products that use some of these advanced technologies and wearables, you need to take this into account. And again, we've heard about the medical algorithms. I'm not going to go in details about medical algorithms, but clearly, if you have data that we know from the beginning is already biased, if you just put it into a product that uses the data, that product is clearly going to be biased. So algorithms are perpetuating bias, and we need to make sure that we're putting in the tools and monitoring to understand the impact of these algorithms on perpetuating bias. So I'm going to talk about 3 big problems we have. And if I was giving the talk on the framework for implementing digital health, the first thing I always talk about is you have to solve a big problem. So I'm going to talk about 3 relatively big problems we have. So one of our big problems, and it's not just us, it's across the board, is the issue of hospital readmissions. Hospital readmissions, depending on the initial pathology, are anywhere from 15 to 25%. That means 1/4 chance if you came to the hospital, you're going to end up back in the hospital within 30 days. And why? It sounds like that's ridiculous. It's because when you get discharged, and a patient gets discharged, the follow-up and what needs to occur, including the medications, the instructions, et cetera, are not well coordinated. So the purpose of this slide is really to show that the incidence of readmission at 30, 60, 90 days goes up with the number of health-related social needs. And as was pointed out in one of the earlier talks, our populations have a number of health-related social needs. So hospital readmission is a very important thing to deal with. The other thing, which is really perverse in the reimbursement system, we deal with more patients with social issues in safety net hospitals. we now get penalized more because we don't do as well in terms of reducing readmissions. So we've been fortunate, and I don't have any financial interest in any of the three companies I'm going to discuss. And the reason I highlight them is because they've been willing to take on difficult challenges and work with us to try to move the needle forward. So one is Memorial Health. And what we are doing with Memorial Health is initially we were calling patients after they were discharged to try to see if they got their medications, if they had their follow-up appointment, et cetera, et cetera. I was using 3 nurse practitioners to try to get this done. And if you know salaries around nurse practitioners, this gets very expensive. And we were only reaching about 1/3 of the patients. A bunch of people did not answer their phones. And think about yourself. How often do you answer your cell phone? Right? If I see a number on my cell phone that I don't recognize, I don't answer it. Whereas if I get an SMS text, I'm much more likely to answer it. So essentially what they do is they've constructed an app, uses artificial intelligence and chatbots to engage patients in an SMS conversation. So they have a whole suite of issues, but we focused on one small use case. And again, back to the framework, talking about when I'm implementing any digital health solution, I want one simple use case in order to show that it actually has value. I'm not going to implement something really complicated at first. So all they did was they sent a message to patient. We are, whoever, we're contacting you. You've recently been discharged from the hospital. We'd like to engage you to help you through your recovery. And we have about 70% of our patients compared to less than 30% of our patients who are willing to engage with the chatbot and go back and forth about their discharge, their medications, et cetera. As has been talked about, maternal mortality is a huge issue in Black, Hispanic population. 4 in 10 births are covered by Medicaid nationally. Black maternal mortality is nearly 3 times the rate seen in white women. And twice as many Black and Hispanic women are on Medicaid compared to white and Asian Americans and Pacific Islanders. So women of color face significantly higher rates of maternal mortality. This disparity exists across all income and education levels, and there's inadequate access to quality health care and certainly systemic racism. So we are working with a company, Baby Scripts, and I believe this is a pilot that's being run across New York State, and it's been sponsored by Baby Scripts as well as New York Department of Health. And again, it's an app-based program and enhances and extends the reach of clinicians and payers through remote tools, driving risk management and effective interventions. And it's multi-pronged, educating and empowering the moms, stratifying and identifying people who are at risk and try to identify them earlier, being able to activate the care team, improving access, and automating solutions to efficiently manage members of the care team and reduce complications. So what's the impact? 13-day reduction in time to detect preeclampsia, 50% reduction in the prenatal no-show clinic rate, which is key. We still have a huge problem, especially amongst teens, not showing up for prenatal visits and then presenting in labor to the hospital. And a 400% increase in mental health screening. So the last major issue that I'm going to talk about that we have is our HEDIS measures. And these are outpatient performance measures, how well hypertension is managed, how well hemoglobin A1C is managed, cancer screening, a number of different measures. We have a very difficult time in meeting the HEDIS measures for our Medicaid outpatient population. We are losing about $1.7 million in potential income lift because we're unable to really move the needle. So we actually have identified a startup, their name is Twig, who is specifically looking to provide concierge outpatient services to the Medicaid population. They are specifically targeting the Medicaid population with this app. It does use artificial intelligence, but importantly, it has a personal touch. So one thing we've seen with some of the other apps that only use chatbots is a reluctance for some patients to use it. This actually has a personal touch and a nurse in the middle. So there's always a human licensed nurse, all SMS text, empathetic, culturally aligned, but it's supercharged by artificial intelligence. So this is what a conversation would look like. So you contacted by Twig, let's get started. You were recently discharged after knee surgery. How do you feel? How is your knee doing? Patient responds, thank you. I feel nervous walking around. You then still have the nurse communicating with the patient, but after this, when the patient says, how long will it be before I feel strong again, there's the opportunity to use artificial intelligence to help generate the answer if the caregiver does not have a complete knowledge set. So this is AI generated based on the conversation that took place. And you can read it. It's actually pretty good within 4 to 6 weeks after knee surgery. And what is critical is that we don't just send this message automatically. This message, before it's sent, is reviewed by the nurse. The nurse could just press send and send this automatically, or they can edit the response. Very minor edits, but this program provides a human interaction and ability to really improve the interaction. So what have we seen? Specifically, our use case, we're not looking at all the HEDIS measures. Again, try to simplify the initial pilot. 60% of the patients engaged. The number of messages per month between the patient and the system, and 45% of the patients that were targeted actually signed up for the cervical cancer screening. So that's just a little bit about how I think about digital health tools, some of the experiences we've had in implementing a few, but really, back to the initial introduction, I'm concerned about the issue of health equity in the digital age and how we can make sure that we don't make the disparities, which we all know exist, worse during this transition. So thank you.
Thank you, Dr. Berger, and that was better than evaluation anyway, so thank you, we appreciate that. Could Dr. Pagler, I keep saying your name wrong, I'm so sorry. Dr. Pagler and Dr. Bajaj, please come up for quick question and answers. I'm so sorry. All right, so feel free to come up to the mic. I'll start with the first question while you guys are thinking about it. So is there a particular point during the implementation process of digital interventions that you find health-centered organizations consistently stumble on? since you always kind of spoke to process in some way.
Consistently similar?
Consistently stumble on.
So it depends if you're looking at it from the aspect of the company or the organization. So from the aspect of the organization, I think there's one thing that we've consistently stumbled on, and it goes to the issue of security, is how can these third-party companies engage? What level of consent do you need? And how do you get that consent without reducing the ability for patients to respond? I'd say that's one. I'd say the other thing that we've struggled with is the issue of cultural appropriateness and cultural sensitivity. We have a large Caribbean population. We have a large population that speaks Haitian Creole, and no one has part of their standard list of languages Haitian Creole, so we have to go through that as well. But I'd say the most important, the one thing that people don't really appreciate is how to go about getting permission to do these things.
I really appreciate that. And one of the things that I will add is, as you go through the vetting process, you pick a solution, really mindful of what are we taking off of people's plates? And it's the hearts and minds change, right? Patients are busy, our staff is busy, and so really having clarity of thought around what is coming off of plate, I think is really important, and often we stumble upon.
Yeah, I would agree with both of those. Someone on? Yeah. And then just to highlight again, I think some of the points that you made, I think it's there's kind of what do we think about as we're starting, but then also what are we doing, what are we measuring as we go along? And I think there's so many things that we don't realize are issues just because we fail to measure or fail to think about it. And even in our example, we've been doing this work for 10 years before we realized how big a problem we had with what we thought was really working. And so, thinking about the populations you're trying to serve and what disparities you might be worried about and measuring that early and often.
Yeah, I think that's a great point, and I applaud Kamal for going through really all the steps and what you were measuring and how you were measuring, because you really have to set the measurement up at the beginning, or else you'll never know if any of these solutions are doing anything positive.
Thank you very much. And just a quick note on cultural sensitivity. Do not ask your patients if they are experiencing the itis. Throw that out there. Next question, please.
It's exciting to hear that the text box are able to outreach to patients and get them engaged. I'm curious from a risk and data perspective, what is the turnaround time to get those conversations and that information back into the patient's chart so the rest of the care team can see it? What does that gap look like, and how do you bridge that?
Well, just kind of adding on to the problems that we just talked about, one of the major problems is thinking about how you integrate everything into the workflow or into your main systems. And I think that challenge of speed to trial and being able to kind of fast fail when something doesn't work versus doing the extensive work that it takes to fully integrate something both into the information system and into the healthcare system is a constant challenge. So depending on what type of intervention you're talking about, that varies. So for example, we're doing large language models integrated into our portal message responses, which comes as part of our large vendor package. That's all integrated, and you can see that immediately, and that's, you can see both the responses, you can see that whole thing immediately into the patient chart, and the care provider can see it, but we're also looking at some of the individual chatbot companies, and those are a different story for us.
And so the other organizations here have Epic as their EHR. We do not have Epic as our EHR. We can't afford Epic. We don't have the number 2 in the market either, so I just don't want to disparage the number 2 in the market, and I won't name who our vendor is, but we can't do that. it's almost impossible for us to take the messages from these chatbots and get them back into the EHR. We have to have a separate work stream for that.
Hello, my name is Julia. I work at Children's Hospital of Philadelphia in research. I wanted to ask a question that Dr. Berger referred to, which is about money and healthcare funding. Thanks for speaking about it frankly. Being in this room of public health people, I was wondering if the panelists would be willing to talk about, in an ideal world, how healthcare should be funded in this country.
So there are different states that are looking at it from a different lens. I would say the one state that's probably the furthest along is Maryland. And Maryland has what they call the all-payer model, where every payer pays the same thing for the same DRGs. That makes a huge difference. So you work at CHOP, you understand, and most children's hospitals struggle because they have a huge Medicaid population, but luckily people like to donate to children's hospitals, so it sort of makes up for it. But the big hospitals that don't have the same degree of Medicaid we have generate huge margins. Huge margins. I won't name who, but there's another big system, academic, not in New York, not in Philly. They only have 17% Medicaid. They make more. They have about $13 billion in the bank. And their CEO makes more than a number of for-profit CEOs within the healthcare space. So it's hard to justify a $6-9 million salary when you're a nonprofit institution. It's a challenge. But Maryland, I think, is the furthest along right now.
I would agree. I think it's for those that aren't familiar, check it out. It's a really interesting also story how they sort of got that far ahead. I think, for me, the comment that I'll make really as it relates to policy and how we pay for things, I'm really interested in sort of legislation that sort of puts some of the onus on vendors. In order to get paid, in order to become a vendor, you must have these sort of basic things. And some of those would absolutely address health equity. Even I was looking at some data the other day around environmental justice and carbon footprints. It is a secret, what is the carbon footprint of some of the products that we use, and yet in other parts of the globe, it is a requirement for those same vendors to share that data. And so I'd like to see some legislation around that.
Well, in case you're curious, ChatGPT uses more electricity than some countries, like Costa Rica, Guatemala, more energy for that one large language model. Your point about vendors is really important. And I think it goes back to how we pay for things in this country. So if you look at med devices and pharma and what their profit margins are, 25 to over 30% profit margins, compared to even hospitals across the board, take profit, nonprofit, it's only 3 to 4%. So it's not like healthcare is a high margin business as a provider. So great point in terms of the vendors have responsibility for where we are as well.
Yeah, I don't have anything amazing to add except just to emphasize the points you made. We're lucky in my area in that for children at least, everybody is covered. So whether it's Medicaid or our local county health insurance product, all children, regardless of legal status, regardless of anything, can get health care coverage. But it's 11 cents on the dollar. And so we're about 40% Medicaid in our organization. And I think our CFO says, 1% shift either way is like an $11 million hit to the bottom line. And so it's not just about like are you covered? But you know, how are those what are those reimbursement rates compared to other reimbursement rates? So yeah, it's just such a huge issue and makes such a difference in the care that our patients receive.
Thank you. I think we have time for maybe 2 more questions just to stay on schedule.
Hello, thank you for your presentations. My question was regarding Dr. Berger's mentioning of AI promoting cervical cancer screenings. Are there other examples where AI can be used for preventive and even proactive care?
Sure. You know, I think yes is the answer, and there's all kinds of excitement in the field of clinical informatics. We have been looking for a long time about how different types of computerized clinical decision support can help guide the right types of care, make care more efficient. And in my mind, this is just kind of the next step, the next evolution of those tools. I think it's important to remember that whenever you're trying to implement a technology solution, it's about people, process, and technology, and the technology is like the 5%, and it's really about people and process, and thinking about how are you going to implement that tool into your system? How are you going to make sure that it works with your processes? How are you going to check the results to make sure that you're not creating unintentional consequences? So yes, these tools are getting more and more powerful, and I think there's lots of excitement, but there's a lot of work to do to make sure that they improve care without kind of causing unintentional consequences.
I actually think probably the most exciting thing in clinical medicine, looking at AI, is the ability to identify disease earlier than we currently do. There are AI large language models, especially in healthcare, that can comb the EHR labs, et cetera, identify patients who are at risk for certain diseases. There are AI tools now that can find cancer or detect cancer earlier in mammography, chest x-rays. Also, there's pancreatic cancer earlier. So in my mind, the most exciting thing is early identification of disease and potentially disease prevention.
Couldn't agree with you more, and I would spotlight for this group some of the work around diagnostic excellence and in advancing diagnostic safety. The National Academies is actually specifically convening a group to think about AI in that space, because I think you're right. That's where my exuberance is as well.
All right, one more.
Dr. Richardson was talking earlier about access as well, and a lot of this is only dealing with health equity, but how to get it actually into the places where it would reach those people the most. I work at a federally qualified health center here in New York. We are out in Jamaica in the Rockaways. We are ignored by a lot of different organizations. We have one bioinformaticist. We saw 40,000 individual patients last year. So even if we had companies that gave us access, I'm the HIV/STI prevention program manager. I'm building forms and order sets and all of that in our system. So how do we actually get these apps and services to the people they need it most without putting more work on the people who are working there?
Don't
look at me. I don't have an answer for that one.
Well, I think it goes back to some of the discussion that we had earlier today, right? When it was asked, well, you know, the academic medical centers will have these solutions. What about the FQHCs? What about sort of the municipal health systems of the universe? You know, I think that, you know, in the spirit of absolutely honoring the situation that you're in and the scarcity of resources that you have, and I would say that, you know, the point is to start somewhere, anywhere, right? And so I would go with, what are the regulatory and accreditation requirements tell you have to do, right? What is, you know, we still have some not so great data, right? It's still not, you know, where we want it to be, but with whatever data we have, how can we get started?
The other place I would start, and which is really easy, you don't have to use any fancy tools, is administrative work. Yeah. So the ChatGPT, whichever flavor you like, Bard, Gemini, ChatGPT, Perplexity, whichever one you like, for administrative tools like generating position descriptions or generating policy or those kind of things. Those tools are amazing right this second. All you need to go in there is say, I want to generate a job description for a new nurse working in the FQHC who does primary care designated for children. You will get just about 95% perfect job description. So I would start not on the clinical side, I would start on the administrative side.
Yeah, it's a super good point. And then I would say, I think the other important piece is your voice and your partnership with the AMCs is so critical. And so, I know my team is incredibly well resourced, and we are lucky to have the team and the technology and the resources that we have, and because of that, are trying to figure out, one, how can we figure out the best path forward? How can we share that? How can we, I said, partner with our vendors to get them built into vendor systems at our vendor system, realizing that that is not a affordable vendor system for everybody. How can we then affect the policy? And how can we partner? How can we partner in certain programs? So, like the PrEP program that I showed is a virtual program that is designed to support any system in California, and so people. Any pediatrician can refer to that virtual PrEP program, and then our providers will help with the PrEP prescriptions and monitoring while keeping them at their primary care provider, and our resident clinic is a FQHC, and so we partner with them a lot. But I think there's interesting opportunities like that when there's good conversations happening between the AMCs and the people who are really meeting the needs on the ground. And so we'll continue opportunities like this and partnerships like that to really figure out how can we work together to solve some of these bigger solutions.
So we're going to squeeze in one more question because the nice lady in the back was standing for a while.
First, I want to thank you for taking my question. I am Michelle Booker. I serve on the Harlem Hospital Community Advisory Board. So thank you. My primary question is, you've been talking about equity and privilege throughout the system. One of the biggest challenges for those who are underserved is time. Privilege is a time. And going to the doctor, even today, their hours are 9 to 5 or 9 to 4. Most people in those situations, or economic situations, even if you are earning good salary, you don't have enough sick time. How can we build in time where people can go see their doctor, or at least get to their office between the hours of 3 to 8? Because we have diversity of how people are earning income, we need the healthcare system to approach it from a space that there's also diversity of time where people can have access to their provider.
So, in my mind, running a hospital and an outpatient unit, we're not a bank, right? It's not 10 to 4, and we can't provide care like that. So I agree with you 100%, and we've moved. I know H&H has done a great job with this, but we've moved to after-hours clinics for most of our services, Saturday clinics. Our doctors we're an academic institution. We're very used to 9 to 5 in terms of our clinics. People need to understand the impact on an hourly wage worker who doesn't have 4 to 6 weeks worth of vacation, and who don't have caregivers that are available all day long to take care of children, parents, etc., who may need care. So part of addressing disparities is changing how we provide access, no question.
Without a doubt. And, to that point, the equity lens that I mentioned previously, we spend a lot of time, and as teams, I've been promoting them to think about time of day and day of week, because you're right, it matters. The other thing on the legislation front that I have to plug is an OBGYN, right, in the state of New York, right, prenatal care now is covered time. Right, and so I think our voices matter, and it's heartening to see that politicians are beginning to see what you just mentioned as an imperative.
I mean, I don't have anything to add. It's such a critical issue, and I think that. Well, sorry, I don't have anything to add except that I do think that some of our digital initiatives have given us a way to decrease the travel time that can go along with the time that's needed to take out. And again, coming from a pediatric perspective, where the children's hospitals are few and far between, I think looking at different ways to reach people when and where what they need it is an opportunity.
Thank you all. Sorry, no more questions. Appreciate it. Waters for you guys. More. All right, so we're going to move into our final session. Thank you for all the engagement. These have really been great questions and great conversation. Nobody wants to just sit here and listen, so thank you very much for participating. Our last session is Impact of Digital Tools and Communities. This will be more of a fireside chat, so it's really a conversation that we're going to be having up here. We're going to bring up Dr. Jorge Rodriguez. He is a clinician investigator from Brigham and Women's Hospital, and Angelina Saul, who is a licensed social worker and program officer for foster care youth from the Conrad N. Hilton Foundation, who's also our sponsor for this event, so shout out to them. And we will have a moderator who will be Dr. Cheryl Smith, who is the leader and visionary of the Digital Health Initiative here at the New York State Department of Health AIDS Institute. Cheryl's in the middle. All right, thank you very much. And take it away.
So good evening. As you can see, I know the slide will come up and it will show me as a black male. So I'm not him. He's absolutely amazing, but he was unable to join us today. He doesn't feel well. So unfortunately, I know it's going around. So it's me. Lucky me. I've been on the phone calls with these two, and they're absolutely amazing. So we will start and hop right in. So this is really a chat, and it's also a chat with the audience. So hop up to ask your questions, for sure. It will be a chat with us, but I want to actually engage you as much as we can for the limited time that we do have. So we'll just start off by, what does equity mean to you? Because I know you have a lot to say.
I do, and I will try not to preach to the choir too much. So what does equity mean to me? So I am going to speak from a funder perspective with a social work flair. So for me, what equity looks like in my day-to-day work is ensuring that the projects that the foundation and my initiative are pursuing and potentially supporting, that those projects have been developed with a couple things in mind. One is the youth that we're seeking to serve. So for us, that's foster youth, transition age youth from 12 to 14, all the way up to 26. And so how have those folks been engaged in this project? Because what we're not interested in is projects that have not centered the lived experience of the people that we're trying to serve. And have they gone beyond sort of these like advisory, check the box, yeah, we asked the kids a couple questions kinds of conversations? How are we actually empowering those with lived experience? Again, for me, that's foster youth in the system or have aged out. How have they been engaged in the development of the project, the testing of the project or product, the feedback loops in terms of improvement, and in the outreach? And so for me, equity really means that those that we're trying to serve have been meaningfully engaged in the work that we're trying to do, and that work represents the true life experience and the real problems of that particular population, and not the perceptions of those in a room somewhere who have decided what the issues and what the needs are for those issues.
So thank you for that. So I'll sort of twist that question a little bit, and I'll go back and say, you are one of the funders for our conference in terms of the Conrad Hilton Foundation, so thank you for that. So Jorge, Dr. Rodriguez, I'd really like to find out from you, I know you've said that essentially in terms of digital health, it's been very much hyped, and we haven't necessarily lived up to that hype. So can you describe where we've fallen short in reference to that?
Yeah, it's a great question. So many places, but I think a lot of it comes like what was mentioned already in the previous conversation, comes from like this like buy-in, this kind of a term of like techno-optimism, right? We're all here because there's some belief in us that we're like, technology is good. Technology will like help us address things. But I think we have to increasingly go at it from like a techno-skeptic standpoint, where we're like, do we really need the technology here? And has technology served us before? Like there was a mention of like prior policy in the past. So for example, patient portals are sort of like a great and also not great example of the way technology in healthcare has been integrated and maybe failed us in a lot of ways, right? Patient portals, a lot of them came up like HITECH Act, and that time, this was back in 2009, 2010. But even till now, if you look at probably your patient portal in your organization, you'll see those gaps across language, across race, across ethnicity. And so where we've gone since 2009. And so I think that's where a lot of the challenges have been. And even then, if you just say like focus on access and use, if you then take a step further and say what meaningful impact has it had on the community that we're going to talk about, or on some of the health outcomes, the data is mixed. It's not like we gave someone a pill and like giving them whatever technology was the equivalent. We're like, oh my gosh, we should do this for everyone. So I think it sort of has pushed me, and I'm an informaticist, it pushed me to take a step back from my kind of, my love of technology and say like, is this really doing what I think it's doing, what I claim it's gonna do? And I'm not, I used to be more sold, I'm not completely sold right now.
Okay. Okay. So I'm not saying we're in the middle of COVID any longer, but we have going through COVID, and we had a phase before COVID, and now with young people, what changes have you seen as it relates to digital health after the impact of the COVID pandemic?
It was interesting because I was working in community mental health before the pandemic, during the pandemic, and after the pandemic, if we can say after. And I came up as a social worker in a time where it was like, you can't do this work remotely, you have to be in person all the time. And then the pandemic happened, and we recognized like, wow, a lot of things can be done virtually that we hadn't thought about, written off, what have you. So I think that was really important because we were able to continue to serve our clients, see our clients, check in on them, do the best that we can. Fast forward to where we are now, I think we all appreciated the efficiency of that kind of modality. In some ways, for the families that we have served and the youth that I'm now serving on the initiative, they have so many constraints on their lives, their hours of the day. We heard about that from the question earlier, that the return to coming back to the way that services looked before pandemic has been really bumpy. And I'm not advocating that we have to go right back to where we started before 2020, but I do think that for our youth and the youth that we're serving, there needs to be some hands-on eyeballs on these children and their families, right? They are so vulnerable. There are so many challenges that they're facing when they're in the system and coming out of the system, that trying to re-engage them back into relationship, which is already hard for them because of their trauma histories and all the things they've been to, has been really hard. And so I think that what we're trying to support folks in doing is, again, going back to the youth and asking them, where is the middle ground? What do you need? And I think a lot of times the answer is the spaces need to be safer, more accessible, address all of those social determinants of health. And we as a system and as culture haven't done a good job post-pandemic in addressing those things. And so I think until the tension that lives there can get resolved, humans are gonna rely on what's easy and fast, and that's the digital stuff, even to their own detriment when we know that healing and hope becomes installed through actual interpersonal relationship.
Have you seen anything, in just to that vein, have you seen any specific strategies that are being used that have been successful in terms
It's
of
funny that you
people?
ask. I think obviously the Why Get It app and, the tested graphic novels that we have out in the lobby, and really those tools that are digital on its face, but then also have linkage to peer supports that are embedded in there and do create, again, that sort of feedback loop of what can be accomplished digitally and virtually. Where is there a handoff that needs to happen between a person or a clinic, and then back into the technology as appropriate, and sort of having that revolving door and having tools that actually speak to the users in the way they want to be spoken to. So again, for me, teenagers are our target population. Teenagers don't talk like us, by and large. They don't access information like us, by and large. And, again, having apps, tools, pieces of information that don't sanitize the experiences of our youth and really speak honestly to them, about them, I think have helped start to bridge that gap, because it instills that sense of trust and safety, right? If the app feels like, oh, this resonates with me, this is sensitive to who I am as a person, what my culture is, maybe I will give those human beings in that office a chance, because they do seem to have some sort of understanding. So I think the better we get at that in the technology, it will instill enough hope and faith in our youth to be able to make that jump back into relationship.
Okay. I think one of the things that we had a conversation about was how it is that you engage seniors in Boston. So if you can describe how it is that you have successfully, or you've seen programs successfully engage seniors.
Yeah, I think it goes back to that one-on-one connection, the people connection. I think one of the more impactful things we've done in terms of seniors and communities has been our digital access coordinator program, which is a digital navigation program set in the healthcare setting. And that way, it's sort of a group of staff whose whole role is to sort of engage all patients, but with some focus on seniors, on how to bring in, whether it's the patient portal, remote blood pressure monitoring, continuous glucose monitoring, any of those kind of like healthcare-based technologies into their care. And it's been really interesting when we've had conversations with the digital navigators. They both find when they care for or they support seniors very challenging, but also very rewarding in the way. And so we have countless stories where it's maybe taking a few times that the senior has come to the clinic, and each time the navigator is there and like, hey, there's this like new tool, you could like help. The senior's like, no, that's like not for me, I'm not really into that kind of thing. And then eventually after a few times, they're like, okay, I'll give it a shot. And they give it a shot, and they're like, whoa, like they sort of find themselves that they now can use this technology, but it took that kind of digital navigator to make that connection, to maintain that kind of connection that we're all looking for in the end of that relationship, right? People come to healthcare system for the relationships that we're building with our care teams, not necessarily to like interact with a computer per se. And similarly for clinicians, like I went into medicine because I like people and I like caring for people. I didn't want to care for a computer. I did become an informaticist, so that's a separate story. But I think it's
that happened.
Yeah, exactly. So I think that's been one of the more sort of impactful ways that we've been able to engage seniors, is just maintaining that people connection as a way to connect them with technology.
I mean, I think one of the things I've found in terms of seeing patients is they are often afraid of the technology portions of it. I think seniors that are, I'd say probably 70 and up more so than anything else, but once they have someone holding their hands through the process, even in terms of getting my chart, if you're using Epic, my chart, and getting it on, getting it into their systems, often they don't necessarily have a smartphone for my chart, but their children will get them a smartphone. And it's really having someone to help them navigate that for the first couple of times that it's been very, very helpful as it relates to that. That said, I mean, let's talk about any new trends that you are seeing amongst the youth as it relates to digital technology? Anything that you've seen as it relates to trends?
Okay. I mean, I think, in terms of trends, actually, most recently, I think I'll highlight, I guess, two trends. I'll take two trends, if that's okay. I'll take two trends, if you allow me. One trend I think has been highlighted a lot has been large language models and ChatGPT. I feel like you got to mention it as a trend that's ongoing now, so I can step that. I think the challenge here has been highlighted is sort of what's the I think sometimes it's like, what's the use case? And I think we've seen some good use cases here, but I don't know if we've completely gotten we're sort of going like investment, like the amount of investment, and I'm talking financial time investment that's going into building these tools is impressive. But I wonder if that same energy, investment, and time were invested in other areas of our patients' lives, if it may not make a bigger impact. And I think that's sort of where I struggle from a technology standpoint to say, let's push for technology, but then we sort of talked about the diffusion of these technologies already, well, to academia, but will it get to my local clinic? And that's where I struggle, I think, in terms of a trend where I just see increasingly push towards investment in technology, but there are other areas, you go through the SDOH wheel or whatever, you can take a look, and investment there might make a bigger bang for your buck, right? Like I think investing for my patients who have diabetes, perhaps investing in some of these tools might impact them, but how would investing in food insecurity, housing stability in the same effort do it? And so that's sort of where I struggle. That's sort of one
This
trend.
is speaking from an informatics person.
Yeah, so yeah. Yeah, from an informatics. No, I mean, I think you have to take a step back and realize that. I think that's sort of, and then the other thing that's come up a lot within the past week that I'll highlight is sort of some of the sort of in the vendor space, some of the, at least with telehealth, some of the step back, like Walmart Health kind of taking a step back from their stuff, Optum selling some of their kind of telehealth platforms. And so I think those pieces, again, make you kind of question what was wrong there, what was the challenge that they faced. And all of this, we're all learning, right? It's not saying that like, I have all the answers, or oh my gosh, they're wrong, how could I do this? It's like, what are the lessons learned there that we can say so that maybe the investments that went in there for the next time this happens could be better invested. So I think that's sort of the other point I'll highlight.
Did you have?
I think the only thing I'd add, again, speaking sort of from the youth perspective, and Dr. Pazer talked a lot about this, is sort of continued attention for youth users and what needs to happen in these digital platforms for them to have the confidentiality that they're entitled to be able to consent in the way that they are legally able to be able to engage in the way that they want. And I do think that we are trending in the right direction in considering those things, which is nice, because again, if the teens don't trust the system, they're not gonna use the system, and then what have we invested in? It's a big question mark.
Just going to follow up, because in our prep calls, you mentioned the representation being important. So if you can talk a little bit about representation within the digital space.
Sure, yeah. So in our Foster Youth Initiative, one of the, so we fund around sort of sexual and reproductive health. We also fund around education and career pathways. And those two things might not seemingly be related, but for us, we're so interested in the centering of the lived experience that if we want these tools, digital enhancements, whatever's coming down the pike, to be really thoughtful of the youth experience, of the experience of young people of color, different gender identities and SOGI identities and all those things, then we need them to be represented in the actual tech development fields. And so we need to be investing in our Black and brown youth, our foster youth, our other sort of under-resourced, intentionally under-resourced populations to get them into these career pathways so that they can bring that experience into the actual development and testing of these tools, instead of sort of being the guinea pigs on the back end to say, well, this doesn't work and this doesn't make sense. We need to have them way, way, way up front in that development process.
Okay. Anything?
In terms of representation, no, I agree. I think it's going back and having, I know at my organization, there's a slew of different groups that engage both high school students, undergrads, and the like, and kind of engaging in these conversations. And I know on the informatics side, there's a lot of work being done in how do we kind of show people the path of informatics as a potential career path, whether that's through like medical school or other places just where you can get, I know there's a lot of effort going on there, and I think that's the kind of work that we need to do to sort of continue that representation and build up the kind of culture that we want.
At this point, we'll open up for some questions from the audience. If you have questions for either of our panelists, please come down to the mic to ask any of your particular questions that you may have. I know you mentioned the fact that you are concerned, I'd say more so than anything else, as it relates to the amount of energy, funding, focus on digital health. I mean, where do you see the largest benefits around digital health and digital tools such far in terms of actual benefits?
Yeah, I mean, I think that some of them have been on like maybe on the clinician side. For example, there's been a couple of papers that have come out recently looking at like clinical decision support for clinicians and improving their like alignment with guidelines. So I think there's been a lot of benefit there. A lot of times when I talk about this stuff, I do a lot of work on the patient-facing side, so I sort of think about it. But I think on the clinician side, there's definitely been an impact there. Like for example, there was a paper that came out recently looking at clinical decision support for primary care doctors and making sure that their patients with kidney disease had the right level of medications that they should be on, and that was shown to be beneficial compared to not doing that. So there are support systems, and I think in the previous talk they sort of highlighted a couple areas where digital tools can make an impact. I think there are examples. It's just there are other examples where it makes me take pause.
Have to pull it out of you.
I know.
So I think another portion, I think Dr. Berger may have mentioned it, is someone else, maybe it was IBM, mentioned it this morning in terms of prior approvals, in terms of physicians' lives, or clinicians' lives, I should say, for nurse practitioners as well as physicians. If you can get AI to deal with the prior approvals, that would significantly affect the clinicians' lives, therefore affecting patient lives as well, because they would potentially get their medications faster, and the amount of time that's utilized to get a prior approval, that would be cut down significantly if that particular system was sort of moved on to a different platform. So I think that would definitely be helpful. I see we have our first question.
Hi, thank you. Again, I'm Michelle Booker, representing Harlem Hospital Community Advisory Board. One of the challenges that the data keeps showing us is the lack of technology and communities that lack them or the service. So at times when a patient is hospitalized, they may have family members who are not nearby, or even those who are incarcerated. How can we ensure that they are able to communicate with friends or family while they're dealing with their recovery? The cost of providing tablets, especially within the public healthcare system, not necessarily that they keep them, but just like there's a TV in your room and there used to be a phone in your room during our grandparents' time, how do we ensure that people have access with digital tools when they're trying to recover? Thank you.
Yeah, it's a great question. I mean, there's a lot of, I think, lessons to be learned from the pandemic, where you had a lot of these moments where folks were you weren't able to visit your family members. So I think there's a lot of lessons to be learned there in terms of like when they deployed, maybe not giving every iPad, but there were iPads available that they made available that you could call out or have a Zoom or make a phone call. I think that's sort of one opportunity where folks can connect with their family members when they're recovering. I think the larger conversation, and I'll take this question to zoom out a little bit and go on. I feel like just going on soapboxes. So there's another soapbox I will go on today, late in the day. It's soapbox hour. So I think it's the sort of conflict of the larger question there is around like, what are the barriers, and they're being covered today in terms of affordability and all these pieces. But one of the interesting pieces that we're having this conversation is right this past month, as you all probably know, and maybe as we mentioned earlier, the Affordable Connectivity Program, which was a big program which provided internet subsidies and phone subsidies for patients, was taken down basically and let kind of subside. And so we have this interesting conversation happening where on the one hand, we're all saying like, digital tools are like really key things, and we have to sort of really focus on this, and ChatGPT is going to do all these like great things, but on the flip side, we have policy that sort of is like it's contrary to that, right? If you look at the policy, it would tell you that we didn't think that because we're letting these things subside. So I think there's there's like things the hospitals are doing that you can do, but there's a larger conversation around policy where before the ACP program was like a good thing. Whoa, look at that. And now it's kind of like a wait, what? So that's sort of a challenge there.
And I'll also say, as it relates to communication with family members, I think that's one of the things that was improved during COVID. Specifically, we've somewhat learned a little bit for that 3-year time period where you're able to communicate with, the patients are able to communicate with family members when you're in the hospital, that was significantly improved, whether it be FaceTime or Zoom or the like. So I think that did improve after, after the immediate impact of the pandemic. In terms of even the staff's ability to assist patients with those digital tools. I think that's where digital technology tools significantly improved for that.
Yeah, I'm just thinking about our foster youth, and accessibility is a challenge, right? Depending on where they're placed, if we're fortunate that they're placed in some sort of family-based setting, that still doesn't entitle them to a device. And so how are child welfare departments ensuring that, for all intents and purposes, this is a basic need now for our youth. And so if we have a responsibility to meet their basic needs, where does digital accessibility fall into that when the children are under the purview of a child welfare agency? I think that's a real question that we ask, and thankfully I think ACS is one of the more progressive child welfare departments. I also fund in Atlanta, Georgia, and so this conversation would be so different in Atlanta, right, for some of the reasons that Dr. Paisler talked about. And so it's interesting in California and New York how we talk about this and then how we talk about it in our other geography of Georgia, right? I got lost in my politics for a second there. It did. So I think that, placement considerations are important for our youth. If they're in group care, how safe are they able to have their devices? Are those being stolen? Things like that. And so I do think that for our work within child welfare, making sure that this is incorporated in that needs plan that all children get, so that we have some theoretical accountability that we can attach to social workers and these systems to ensure that these youth are being equipped to access the kinds of resources that we know that they need to be able to do. And they need to be able to do away from whatever their care providing situation is, whether that's a group home, a family home, a kinship home. It needs to be workable wherever this probably mobile child is going to end up.
Okay.
So I had a quick question about capacity. Just about every presenter touched on it in some way, shape, or form in their presentations. We all work in industries where we're overworked, underpaid, and don't have time to do things that are extra, right? So presenting things that are supplanting processes that we already have in a more efficient way, and presenting that is really important. How do you fill in that spot and have the person who can help the older person use the app, or make sure that the messaging is aligning with your target population if it's foster care youth, or approach and present things to your staff in a way that they don't feel like they're being overwhelmed? There's this new daunting thing that we have to learn. What are your experiences with that, and do you have any advice? And I would invite any of the organizations or folks who are dealing with a similar issue to please come up and talk about your specific issue, and maybe we can get some solutions to that.
Sure. It's a great question. I mean, I don't know if I have solutions. I will say I loved the way Kamal, the sort of the plate the description that she gave. This idea of like what are you taking off my plate? So I think that's a great way to sort of pull it, which I'm going to use now when I go back. So I think that I think a lot of it has been in terms of like the digital navigation program. One of the feedback actually we got from staff is that there was just no, as you said, there was no time for someone to like show the senior how to do these things. And so it was just turned into like, here's a little flyer, here's a little card, and like, good luck kind of thing. And so I think one of the big feedback we got was like, it was great to have them around to know that like there was someone that was going to be able to do this and spend that time. We get into all sorts of questions around funding, and can you have, it's another FTE, so it gets a little bit tricky there when you start going down that path. But I think it's it's making the right investment in the areas where you can then say, hey, we're investing in this area, so we're taking this off your plate. And I think that's a great way to put it. So Kamal, thank you for highlighting that.
I think from a funder's perspective, one of the things that I'm really interested in when I'm working with our partners is having the discussion about how much time and money things really cost. And I think for funders to do better at listening to that and funding true capacity to do the thinking, planning, and implementation that is required for good programming, right? As a funder, I'm not interested in just like funding a project for the sake of funding it. I really want to make sure that whoever is doing that project has the bandwidth to be able to do that. And so I know, in the philanthropic community more broadly, talking about true cost and funders really responding to that, I think, is important. So for those of you that are in development positions or work with your development teams, being honest about how much things cost is really important, because I get some grant partners who really lowball themselves, and I'm like, I know this has to cost you more money. Tell me that, please. I also think one of the things that we do that's really important is working with our partners to diversify their funding streams and better leveraging available funding streams to then diversify staff and staff roles. In California, we've had a pretty radical expansion of how we're leveraging Medicaid. We've now finally decided to pay for peer delivery services. And so again, thinking about how do we utilize those potentially Medicaid-funded peer support specialists to be doing some of the work so that other clinicians can be freed up to do other parts of the work. And so I think having a blended and braided funding perspective will also help some of the capacity issues that we're seeing.
We can get to your question.
Oh, thank you. My name's Denise Lawson. I'm a data research manager at St. John's Riverside Hospital in Yonkers, New York. I've been involved with healthcare and health initiatives for many, many years. And I want your thoughts on the following. I'm going to try to be as nice as I can be. Sometimes these conversations just aren't the right ones. When you talk about, we want to do all of these fantastic initiatives, they turn into check boxes. We get a lot of money with no return on investment, and there's no accountability for that return on investment. You spend billions of dollars, those communities are still suffering because it's not the right conversations that we're having. How do you include, which is one of the initiatives I'm working on just personally, the community-based organizations in a more impactful way, I'll put it that way, so that larger organizations understand the needs of the community, but not just understand it, they do the work of the community, so that when people come to them, we can say it's not just a checkbox, this is what we've actually done, and this is how the community has actually changed. Because we're not talking about sometimes real issues, or we hear them and we don't do them. So I just want your thoughts on that. Thank you.
That's a big question. I agree. I mean, we're almost always just putting, especially from the foster youth perspective, putting Band-Aids on infected, gaping wounds. But again, from the funder perspective, I think one of the things that we are always looking at in our initiative is how far upstream are you looking? And yes, we fund transition age youth, kids that are already in the system. That is not a preventative approach. I'm trying to fight with my board about that. We're not there yet. But having those individual level conversations with our grant partners of how upstream are you working, where is there opportunity to lean into that. The other conversation that I have with grant partners is really around connection. Are you all are you connected with the other CBOs in your sort of area, in your ecoscape? Are you leveraging each other's resources? How are you working together? And so again, from a funder perspective, I really see my role as connecting and facilitating that work between the community-based organizations. Number one, so that they can get support from each other and managing these wild systems that they're working in. And number two, hopefully have a collective voice to then bring back to these larger conversations and say, this is what we're seeing, this is what our clients and patients are saying to us, this is what we're saying will have impact. And then I also think the third part of that is strong evaluation. We have to have a good evaluation plan at the beginning so that we can tell the story of whether or not this worked and why we think it didn't work. I think I see too many times evaluation gets thought about sort of midway or late way, and it's too late. It's too late to get the data that we need to be able to tell the story that we want to be able to tell. So that's also something that from a funder perspective, we're really interested in making sure is part of that discussion so that the CBOs have the evidence that they need to be able to ask for what they want to do.
Yeah, that's great. And I think I'd highlight, I mean, there's like classic things where like, family and patient advisory councils, there's like programs that do community vans that kind of go out and kind of do that kind of stuff. I think, and this might be a little bit hedgy answer, I think creating spaces like this, like where you can have these kind of multi-stakeholder gatherings to have these discussions are so important. I know in our organization, we do a similar one around language where we all get together and talk about language. We have patients, we have policymakers, we have, folks in the C-suite kind of come together and we all have these kind of conversations. I think these are sort of like high yield, important conversations where you can have these conversations. You have all the people together, and give folks some food, makes it extra exciting. So I think environments like this really kind of can yield a lot of great kind of feedback and understanding between different stakeholders and kind of drive our health equity goals forward.
That was going to be my answer.
Oh, okay. I'm sorry.
So I think that's exactly it. I mean, I think one of the things that the AIDS Institute does really, really well for several years is really listening to the community and then looking at what the community has to say to then potentially develop some programming, which is, I think it's important to listen. I think that's only the first part. Develop a plan based on what the community has to say, go back to the community, right? And see whether or not they think, because you really need buy-in for whatever it is that you're doing. So I think that's really important. But I think programs like this and having various disciplines present is very, very important. I mean, this room today was amazing. I mean, we had CEOs, we had entrepreneurs, we had executive directors, we had community advisory board from Harlem Hospital across the street. We have community board members. We have nonprofit organizations. And I think that's really, you need all segments of the population to potentially affect change and make an impact. So I think that is incredibly important. Can we get to your next question?
Sorry, thank you. I just wanted to, I think maybe actually Angelina already got to the point that I was hoping to share/comment about, which is the idea of storytelling through data. I think that is a challenge that our organization is currently experiencing, and something that we want to build on is the understanding how much gaps there are actually in our I would say process of storytelling, right? Like when we are in the community and gathering the data, the questions that we get asked as an FQHC sort of make, I think, sorry, so there's two parts of like, I just want to share. I think one part of it is that I think as a organization that was founded as an HIV/AIDS organization that became an FQHC, there is this process that we're experiencing where we're speaking a lot of like community-based organization, even this conversation about equity and equality and like what does that mean for communities. And then there's an entirely different world that I'm just discovering about like return on investment. How do you work with your CFO or chief finance officer that is totally like, the mindset is very different. They talk about patient acquisition and physician retention. It's very different than I think what we're used to. So I think that like this conversation about like what languages are we speaking, I think even in like population health, informatics, your folks that are on the ground, your program staff that are with your peers or among the community members, and I think your clinic operations and what have you, I think we all are speaking very different languages that I feel like now I'm in a position of having to translate for every stakeholder that I'm coming across, understand and then translate. So I think I'm wondering if I could make a suggestion for whoever, like, I don't know if AI wants to take this up, as a technical assistance around like what sort of either concepts, frameworks work in this idea of like, I'm finding that I have to prove the initiatives that we have because it's not automatic, it's not grant funded. I have to say to our chief finance officer, this will work, this will bring in sustainable income for our organization through, like third-party payers. So yeah, so I think like an ask for like some sort of technical assistance that really talks about like how do you bring in these different languages together to translate for program staff. And I think another aspect is that conversation about evaluation, because now I'm realizing like my data lives like a Frankenstein data. I have like data in Excel sheets of my staff that are like, they're like client coordination sheets of like tracking their leads. And then I have data in like case management software for EI care and data in AIRS. And while we're lucky enough to be in an organization that's really like pushing for data integration so that we can better track, better monitor, and better tell our story. Still, I am the most backward in like my department that deals in community health and engagement is the most backward in our organization. And I'm finding that I have to like run to catch up to be able to get a dashboard that tells the story that we want to tell, right? Like how many events are we doing? Who are we seeing at these events? Can we get people's names and numbers and like their demographic data and zip codes so that we can make that segmentation happen and see, are we reaching more people of color or not? Are we reaching young people or not? Are we reaching people who have language isolation or not? Yeah, sorry.
Thank you for that. I think, and we actually would love to reach out to you. So a member of the digital health team will definitely sit down with you and see how we can assist in terms of some of those, at least the first question. I think in terms of your health system itself, that's something else. But we'll definitely reach out.
Hi there. So patient surveys and feedback groups and advisory groups are great, right? But do you know of any digital tools or platforms to help gain patient feedback?
Can you say more, like, are you looking like I presume not like just survey platforms, like something?
Right, like outside of, is there any sort of digital technology tools or kiosks or anything like that that you have experience with using to get patient feedback outside of just handing out a survey or doing an advisory group?
Yeah, I mean, I think the one that's commonly used, use it as sort of like interactive voice response systems where like you're maybe getting a little bit more of a phone-based instead of relying so much on text. You have those where you're still doing sort of a survey, but you're sort of reaching out via like interactive voice response are the ones I can kind of think of off the top of my head. And I think leveraging those different modalities to whether it's text messaging, which we mentioned earlier, to kind of do the surveys are the ones that I can think of off the top of my head. But I'm not sure if any other ones come to mind.
I don't have any, but just as y'all have been talking and asking us questions, I think this challenge, at least for the populations that I'm typically used to serving, is families and youth being overly surveilled by various systems, and how that surveillance of our families and kids affects their willingness to want to give us any sort of feedback or information, right? Because I don't know that if I were in some of those communities, I would want to say anything about who I am, what I need, what I'm up to, how well I'm doing. And so I also think sort of considering that dynamic that is very, very prevalent for a lot of our communities and populations has to be part of the discussion, whatever the tool is going to be, because we might have wonderful tools, but until we address the fact that we are over-surveilling families and penalizing people for asking for help, we're not going to get real feedback from our communities either.
Dr. Gonzalez.
Hello. Oh, thank you for that, Angelina. That is incredibly important. I wanted to ask, well, it's sort of like a riff on something Dr. Rodriguez said earlier, and that is, I think of digital health or digital tools as an augmented necessity in our lives. However, healthcare financing is almost a zero-sum game, and technology is often used as a means of efficiency. What we've learned in our communities is those brick and mortar buildings are absolutely necessary and more necessary than ever. If we could have some advice on how not to use our digital tools to remove these brick and mortar and these actual healthcare services, because it will be used by the bean counters, has been used to make more efficiencies that aren't necessarily people-friendly.
Yeah, I mean, I think that to your point, a lot of what we're seeing is can perhaps be reflected in like the sort of pathway of telehealth and a lot of what we saw, right? We saw sort of a big uptake, during the peak of the pandemic, and has since kind of gone down. And as I mentioned earlier, a couple of the larger folks, like Optum, for example, sold some of their telehealth platforms. I think that's one piece, and then from a quantitative standpoint. And then from a qualitative standpoint, I always have this one story where I was talking to a patient. We were doing this work around Latina patients with type 2 diabetes and their sort of perspectives on telehealth. So we were talking, we were doing focus groups, interviews, the whole thing. And I was talking to a patient, we were interviewing them, and I was like, so can you tell me about telehealth? What do you think? And they were like, well, yeah, it like saves me time, like my family can join, I have to save on parking, I save on like time off from work. And I was like, whoa, okay, that sounds, you're hitting all the positives of telehealth. And then I asked, like, so your next visit, like, well, if you offered you telehealth, would you take it? And they're like, oh gosh, no. I love my doctor. I want to go into the clinic. I want to give him a hug. I want to give him a handshake. So I think my sense is that the patients, especially in our communities, will demand that. And two, I think we've seen it bear out. Even some of the clinicians, I think, have not been as like gung-ho about picking it up. So I think we're seeing a little bit of that in the way of thing. I think the finances of it and people pushing for it obviously are challenging. But I think the folks on the front lines, I think, are really calling for maintaining that one-on-one relationship rather than pushing us all towards digital.
Yeah, in terms of telehealth, that was built on already existing social capital between the patient and the doctor. And that doesn't continue with new patients. It makes it more difficult. We have to look at those and use that data to help maintain and not lose a very vital and not well-financed part of our systems.
Totally agree.
So I will let Louise get the last question.
It's not actually a question. I just wanted to address the young lady that was talking about all the different ways in which we kind of understand health equity. What I got from this conference, which I kind of came in knowing, was that digital health equity is a little bit different than health equity. And while digital health equity can be used in a way to move us toward health equity, there's still a difference, there's still a gap. And so what I wanted to say to her is that she asked if the AI could address some of this. We are doing some things to address some of what you're talking about. We have several trainings. We have one training that is on HIV Training NY that helps the organization to look at their work through a health equity lens, the whole organization. So it suggests that you get a group of providers together, community board members, all those things, a diverse group of people to talk about how the FQHC, how the clinic, how the healthcare organization functions. So that's one. We also have a Health Equity 101, again on HIV Training NY, that just gives you basic concepts to sort of lay the groundwork and to level set for people so that they understand what health equity is, the different terms we use when we talk about health equity, social determinants of health, health inequities, health disparities, excuse me, those sort of things. And at the end, we have found out that a lot of people have used it, but at the end of this particular training, there are some case studies to show how people can interact better with their clients, with their patients. So that's another. And the other thing that we developed, since we didn't talk about race a whole lot here, we developed a module called, I'm going to give you the short version of it. It's medical mistrust, and it talks about what I found when we were talking about COVID, and I was on committee. I did several webinars to talk about why people weren't people of color in particular, why they weren't accessing healthcare and why they weren't accessing testing or the vaccination when it came out. And a lot of things I heard were kind of disturbing from some of the doctors. They would say, well, we have this wonderful thing. Why aren't people taking advantage of it? How much can we do? We brought it to them. And I was like, but there's a lot of mistrust. And I know that everybody talks about Tuskegee, but there's so much more, and it continues to happen. I mean, racism is perpetuated in some of the practices that we currently adhere to. And so we created this module that talks about all of the different ways in which people mistrust and how it's being perpetuated current day. And we didn't just talk about racism. We talked about transphobia. We talked about how people of color, the whole rainbow of people of color are impacted by this. So I just wanted to let you know that we do have some tools. And then the other thing that we're doing at the AIDS Institute is we're writing health equity into all of our RFAs. Have we gotten to the digital part yet? Have we gotten to the dashboard yet? We're working on that. So hold out hope. We're trying. And there is a way to get in contact with us about some of those things if you have questions.
Great. Thank you for that. I'm glad you got up in reference to that. So I just want to thank our panelists. You guys were wonderful. Thank you so much. Thank you so much. And we're going to have Mark come back up and introduce our make closing remarks.
So we've come to the end of our what we did today. I'm not the one who's going to close this out. I have the privilege of introducing the dual director of both the Digital Health Initiative and the Clinical Education Initiative here at the New York State Department of Health AIDS Institute, Dr. Beatrice Aladdin, to send us all home. Happy. Let's go.
Thank you, Mark. All right, so I have the big job of summarizing all of this great and informative information, and I don't know if I collected everything, but I'm going to try and do my best. So, and I'm going to try with a joke first, though. I don't know if it's... So, wow, our bandwidth is nearly maxed out. You get it? Did I land that? Okay. But let's optimize our RAM. You know, RAM is short-term memory on digital devices to process all this digital information and insight we've absorbed today. Esteemed colleagues, cherished attendees, as we begin to shut down, like we shut down every day when we go home, this digital health conference, I wanted to extend my heartfelt gratitude to each and every one of you for joining us today. It's been a long journey to arrive at this moment, very long. And seeing this room filled for our first in-person event since the early 2000s is a testament to the collective commitment to advancing health equity in the digital era. I want to express my profound appreciation to our sponsor, the Hilton Foundation, the Schomburg Center for Research in Black Culture for allowing us to do this conference here, our dedicated Digital Health Initiative team, our supportive AIDS Institute staff, and the incredible speakers who have shared their expertise and insights throughout this conference. Your passion and dedication have truly made this event a resounding success. Special acknowledgement, of course, to Dr. Cheryl Smith for her instrumental role in bringing digital health to the AIDS Institute and advocating for its seamless integration into our work. Throughout the day, we've delved into the intricacies of digital health, exploring the myriad ways technology can be leveraged to promote health equity. While there's been an abundance of information shared, I want to take a moment to try to highlight some of the poignant takeaways. You heard the importance of access, ensuring equitable access to digital health resources and services for all communities. I think that was a running theme throughout all of the presentations today. Culturally competent care, recognizing and addressing cultural nuances in digital health, interventions to better serve diverse populations, You just heard that with the panel discussion right now. Data-driven decisions with Dr. Berger, harnessing the power of data to identify health disparities and inform targeted interventions. I think Dr. Bajaj did a well job of talking about digital safety, prioritizing security and privacy, also Dr. Pagler, in design and implementation of digital health solutions. Safeguarding patient data and maintaining confidentiality are essential to building trust and ensuring that ethical use of technology in healthcare is happening. Collaboration and partnership, we just heard that. Without collaboration and partnership, we won't be able to do this. Building meaningful collaborations across sectors to drive collective action towards health equity. Empowerment through education, equipping individuals with the knowledge and skills to navigate the digital landscape and advocate for their health rights. Without this education, without getting folks' knowledge increased about digital health, we will be left behind. And then the human component in the digital realm, recognizing that while technology are powerful tools, is a powerful tool, it's the human touch that truly drives meaningful change. We found that during the meditation session, right? We were reinvigorated to take on more of this information with that human touch. Let's not rely solely on machines to solve all of our problems. As we reflect on the wealth of knowledge shared today, I urge each of you to consider how you can translate these insights into action. I want to share 4 actionable steps you can take to make tangible progress in bridging the gap between digital era and health equity. The first one is advocacy for policy change. What do? Use our voices to advocate policies that promote equitable access to digital health, resources, and services. Foster collaboration. Again and again, we heard that theme. Seek out opportunities to collaborate with stakeholders from diverse backgrounds to address health disparities in your community, just like everyone in here. Empower communities to take steps to empower marginalized communities by providing education and resource to navigate the digital landscape effectively. Lead by example. Commit to integrating health equity principles into your everyday work and championing initiatives that prioritize equitable health outcomes for all. You can find all of these actionable steps, not in these words, on our website or the mobile. We said it was upcoming, but we were able to put all this information on the website right now, so you'll find it, just scroll down. So together, let us continue to strive towards a future where digital innovations serve as a catalyst to advancing health equity. I want to thank you once again for your participation. It was a really engaging experience. I found it very interesting to see everyone have questions and comments about the conversations we had today. I look forward to the collective progress we will make in the days ahead. So stay tuned for more digital goodness and exciting discussions on the horizon. Until then, take care, stay connected, and we'll see you soon.
You saw the slide with just thank yous, but I just want to say a special thank you to my team. They've been phenomenal, for sure. Obviously, Dr. Beatrice Aladdin, Mark Thompson, Matthew. Matthew has been phenomenal, absolute phenomenal. We had several members at the next slide that started with us when we started this and aren't presently on the team right now. Layla,
Layla McKinney.
Yeah, and Mariama
Cisse
aren't with us, but started this whole process with us, and we really want to send a special thank you to them as well. So please check back, go to the site, there are action steps there. Please reach out to us as well as it relates to digital health tools, platforms. If you're interested in the tested graphic comic, again, our season, the new season, season 9 is out now. It has just dropped today, so please take a look at that. And you can go to Webtoons, you can go to Instagram, you can go to our webpage, whygetit.org, to actually to check it out. Thank you for being here.
Thank you, everyone.